Welcome to the Integrated Care Board public meeting on 30th of September 2025. Integrated Care Board for North East and North Cumbria. I'm Liam Donaldson, the chair of the board. I'd like to begin by giving you the apologies for absence. On the executive side, Levi Buckley, Chief Delivery Officer, has given his apologies. Karen Hawkins is deputising. Saira Malik and Rajesh Nadkarni, partner members, are unable to attend and sent their apologies. And David Stout, non-executive director and chairman of our audit committee, is also unable to attend. Apart from that, everybody's present. If we could move to declarations of interest. So just to flag up item 14, which is the winter plan, which we'll be discussing later, and we are asked to note Ken Bremner, partner members, conflict in relation to being a provider of the plan, but no further action is needed on that. Are we quorate? Our board secretary confirms that. And then the action log and matters arising. Before I ask you whether you want to pick up any items from the action log and matters arising, Hilary Lloyd, our Director of Nursing, I think wants to add something. I'll come back to the minutes of the meeting. Inadvertently passed over that. Hilary.
Thank you, Chair. I just wanted to update around the quality strategy. A new national quality strategy is currently being developed by the National Quality Board, and ours has been shared to support that development. The proposed definition of quality being used is also up for consultation at the moment. The statutory definition of safety, effectiveness and experience is obviously consistent and included. However, they're recognising increasingly other dimensions of quality, and therefore alongside the three statutory functions, wider dimensions such as efficiency, equity, access and leadership that are fundamental a part of the new quality definition. The plan is to publish that new quality strategy in March 26, and in the meantime we'll continue to align to the new developing strategy and continue to work on our quality priorities of safety, effectiveness and experience, and they'll be reported through the Quality and Safety Committee. Thank you.
Thank you. I turned the page too quickly and missed asking you whether you approve the minutes of two previous board meetings on the 29th of July 2025 and our annual general meeting on the 29th of July 2025. Are there any points of accuracy anyone wants to raise on those minutes? No. Okay, thank you. Returning then to the action log and matters arising. Hilary, thank you for that follow-up information. Anybody want to raise any other points on the action log or any matter arising, not otherwise on the agenda? Thank you. Are there any items of other business that you wish to have added to the agenda? No. Thank you. Right, we'll move on now to our Chief Executive's regular report, and Sam Allen, Chief Executive, is going to give that.
Thank you very much, Sir Liam, and good morning, everybody. I just want to start off just by providing a summary of a letter that all integrated care boards and NHS trusts received from our Chief Executive of NHS England, Sir Jim Mackey, last week. And the focus of this letter is very much around the next 6 months, and particularly delivering on what we will and can anticipate as some significant operational pressures over the winter period, whilst also maintaining delivery and financial discipline across the service on delivering our plan. And this is very much built on the work Sir Jim and NHS England have been doing with the Department of Health and Social Care around a financial reset of the NHS and ensuring that we do continue to improve against our operational and constitutional standards that the public expects of the service. So it very much was a letter that focused our attention on the short-term operational and financial imperatives. It does demand of integrated care boards and all NHS organisations that we need to maintain financial discipline, and the role of all boards, particularly in reviewing actual spend across services, what the run rate is on delivery, and also any underlying drivers of deficit, but also performance that isn't meeting standards. In order to support this, NHS England will be undertaking mid-year reviews of selected organisations across the system, and I can anticipate that from an integrated care board perspective we'll be working with and supporting NHS England with those. There's a very clear expectation that all providers improve their performance against emergent and urgent and emergency care metrics, specifically the 4-hour standard on presentation in the emergency department, and reducing the number of 12-hour delays with decision to admit, and continuing our improvement trajectory against ambulance handovers. And you'll see in the board pack today, all boards are expected to submit a board assurance framework, a statement to NHS England confirming that the work that we've got in hand to do that. Clearly, waiting lists and the backlog remains a huge priority of the government, but also from the public's perspective. We know that, particularly through our own work on our Waiting Well initiative, that people's health can be impacted whilst they're waiting for procedures, but not only their health, their ability to work as well. And we've got a session today, particularly looking at our Health and Growth Accelerator and that absolute connection between health and well-being and employment. So we are expected to eliminate 65-week waits by the end of December, and 52-week waits by the end of March. And Jacqueline Myers, I'm sure, will update us on progress with that when we look at the integrated delivery report. From an ICB perspective, we're obviously in transition as part of some of the structural reforms that are being undertaken to deliver the 10-year plan in the NHS, and our move to becoming a strategic commissioner will see us taking a focus on population health and commissioning, ensuring that our local neighbourhood health services have got plans in place, that we are commissioning new care models and working up investment plans, and absolutely maximising both the value and productivity that the NHS pound is getting in our services, as well as delivering local and national priorities. A key ask for us in the letter from Sir Jim is to ensure that we've got good demand and capacity analysis undertaken. We know that particularly in our hospital-based providers and some other community providers, that demand that's avoidable, preventable, can be tackled through alternative means, should be considered, as well as really looking to making sure that we're maximising the potential that advice and guidance can bring, as opposed to always making referrals. We also have a particular role around expanding urgent dental access, and we heard at our last board meeting our strategy for that. And whilst at the moment we're not quite hitting the national target, we have expanded access and we have good plans in place to do that. And then just finally, two further points I just want to cover in that letter. Firstly, around reducing bed occupancy to 80% as we head into the Christmas period. I think for clarity, we are interpreting that as being by 4 o'clock on Christmas Eve. We absolutely know that through that extended holiday period, there can be challenges around getting the right level of capacity across our hospital-based services, and therefore we're really looking to make sure we reduce occupancy by 80% to ensure that we can manage the anticipated demand over that period. From an ICB perspective, we also need to look at alternatives, whether that's in care homes or working with our colleagues in social care with the residential sector. And then the final point is around the importance of personal and visible leadership. And I think as a chief executive, we attended a meeting with all other NHS chief executives recently and heard about the importance of visible leadership, particularly to our colleagues working in clinical services over this period. I'm confident in our system. We have a group of chief executives who do regularly do this. It's not a concern, but I think it is an important note to all of us, whatever our role as managers and leaders, the importance of that visibility, both at the front line, but also in the really important, what might be considered more back office functions, that certainly without those operating effectively, we wouldn't be able to maintain the operational functioning of the service. So the real focus, I would say, at the moment is very much on the short term, getting through winter, making sure that we're improving against these key standards, and that we've got safe and effective services across the system. The other caveat to that is, of course, we've got the 10-year plan, and we know that in order to deliver the level of transformation needed to meet the needs of our population, we've also got to look at wider service transformation. We haven't received it yet. We're anticipating getting it in the weeks ahead, which will be the planning guidance for the NHS. And from a commissioning perspective, we will be required to set out a 5-year plan. So being really clear about the needs of the local population, what our commissioning priorities are to tackle issues such as demand management, whilst also improving health outcomes will be key to that. So within the ICB, our strategy and transformation team has been working closely with all of our NHS organisations and also the regional tier of the NHS to make sure that we are well placed to develop our plan. We have started a piece of work, particularly looking at commissioning intentions and, of course, those priorities that we need to deliver. I think probably what I would say, though, in terms of the work at the moment is we know that we're making this transition to be a strategic commissioner, and we've had to pause our transition and particularly our consultation with our staff on the significant changes we need to make to the organisation. We are seeing our vacancy rate increase, whilst we obviously during this period want to mitigate the potential risk of redundancy. And therefore, as an executive team in the ICB, we've taken a very close look at our key priorities at the moment. And you'll see in my report, we've set out 5 key priorities from planning and prioritising, updating our governance, ensuring that we maintain that financial discipline that's expected of us, whilst also preparing our support for the future. And as part of that, I was absolutely delighted that we had 2 of our 9 sites that we proposed to become first wave of the National Implementation Programme for Neighbourhood Health selected. So delighted that both Sunderland and Stockton are part of the 43 sites selected nationally for the Neighbourhood Health Programme. I think even given the short-term operational and financial pressures, we know that we have to keep moving forward in delivering on the 10-year vision. So whilst there's no pressure on these 2 sites, we're certainly looking to them to spearhead our next stage of work to both integrate health services with between health, between local governments, but also importantly the community and voluntary sector as well at a local level. We've also committed through our own work on neighbourhood health to take forward the other 7 sites that weren't successful getting onto the national programme, and we look forward to sharing progress on that at board at a later date. I do, Chair, just want to briefly mention the financial position that's reported in my paper, and our Finance Director David Chandler will go on to talk about this in more detail in the finance report. Just 2 things I want to say. We are slightly ahead of plan at month 4, which is positive. But of course, we did benefit from a one-off benefit that if we hadn't have received, we'd probably be slightly under plan at this stage. We do continue to make progress across the system in mitigating the financial risk that we were exposed to within the plan, and whilst we haven't been able to eliminate that in full as yet, we have reduced that significantly. Whilst delivering and maintaining our financial discipline this year on delivering the 25 and 26 financial position, we're also mindful that as we move forward with setting a 5-year plan, we will for the first time towards the end of this calendar year receive a 3-year financial settlement for the system. Now, members of the board will know that it's not been unusual in previous years for us to get our financial settlement. It comes on an annual basis, and it usually comes to us to plan and deliver around about the start of financial year, which has been challenging. So the really positive thing in the financial reset that Sir Jim has been leading nationally, working with the Secretary of State, is we will be in a really positive position of getting a 3-year settlement that may come over the next few weeks. Now, I've previously reported to board that the annual allocation that we receive for the North East and North Cumbria using the national funding formula, we believe has certainly presented us with some challenges. So at the current time, we are viewed to be overfunded in our system based on the makeup of the population, that looks at a whole range of indicators, including demographics, deprivation, and the size of the population. And what that has meant for us in the North East, North Cumbria over the last 3 years, is we've lost the equivalent of £100 million off our allocation. We have to effectively pay back a sum every year. Now, I will report to board when we receive our allocation. We haven't seen anything yet, what the implications are going to be over the next 3 years. I am hoping that some work that we have undertaken and our finance director has led, working with other colleagues across the north of England, that we can demonstrate that in fact we aren't overfunded. We believe that we're funding to about the right levels, and therefore we should not be subject to convergence moving forward. But I won't be able to report on that until we receive our financial allocation, so we'll keep the board up to speed with that. Chair, if I may, just a few more things. Members of the public and indeed colleagues working in the service will have seen the publication, and it's the publication for the first time in quite some time across the NHS. I think this was last done probably about 15 or so years ago, where NHS organisations have been segmented between what's called segment 1, and those organisations in segment 1 would be viewed as consistently high performing across things such as access to services, experience and effectiveness of services, patient safety, their people and their workforce, and the way in which they deliver services, and segment 5. And you'll see in my report I've included the segments that our NHS trusts have been allocated to. We do have 2 organisations in segment 4 and no organisations as yet in segment 5. And I am aware, particularly for the organisations in segment 4, that there's been a cause for concern about this, I think, particularly from a public perspective. Each of the organisations have also been given a league table ranking, and our rankings in the league table range from the top one being 9th out of 134 trusts to 130 out of 134. So it gives you some sense of the level of variation and the way in which our NHS trusts perform against those national metrics. Our ambulance service being at number 5 out of 10 ambulance services across the country. So, Chair, if I may, this is obviously the first time these ratings have been used. We will take a supportive approach to work with organisations who, and I know their boards will be examining in full where their opportunities for improvement are, where we've got opportunities to share learning and also peer support across the system, particularly given the variation in the metrics. I think, and this perhaps, Chair, could be the subject of a discussion at a future board, and speaking to my chief executive colleagues in the system, we absolutely would want to set ourselves the ambition in the North East, North Cumbria, of getting all of our organisations into the top 50% in the country. I think we've certainly prided ourselves here for a long period of time on the quality of services, the effectiveness of services. But I think this does tell us a picture, which is we do have variation across the patch, and we do have issues that we need to attend to. And then just two final points. Firstly, we are well underway with our winter vaccination programme, both of the public, but also of NHS and social care staff, and wanting to see increases in the uptake of flu vaccinations. My report also, you've heard me already this morning refer to improvement. I think it's really important that whilst absolutely we've got to have clear lines of accountability and responsibility in services, that we do look at everything we do through an improvement lens, and really delighted that Boost, which is our improvement and learning system across the organisation, this is now the fastest growing learning and improvement community in the UK, and potentially even in the world actually. We've now got nearly 20,000 members of Boost. And if you go onto the platform, you'll see many examples of communities of practice, opportunities for development across our system. This is all open and accessible. And many members of our improvement community are members of the public. And I think that real sense that actually when we're improving services, we need to do that together. And I'm delighted that this month also sees the launch of our People's Hub on Boost, which has over 100 case studies of practical change and will serve as an opportunity to bring together people across our health and care system to focus on improvements to services, and many examples in there such as maternity, cancer services and children's health. And I think that's something that we should be incredibly proud of. And when we are, I think, moving into an era where absolutely we've got public accountability around delivery of services, we've got league tables, we've got expectations, it's very important that we also have an underpinning methodology and approach to sharing learning, making sure we're taking action, and that we're sharing the results of that through Boost. My report does conclude with just a brief summary of a fantastic visit I did to a community pharmacy in Wickham. I think I can really recommend it to board members. I think sometimes through our board we talk about strategies, we talk about plans. There's nothing like getting out there and seeing in action. This is a really innovative group of pharmacies, really adopting things like artificial intelligence. I saw it in action, how that's releasing time and reducing bureaucracy, but also a full range of services to the public through our pharmacy first approach, and implementing our medicine strategy, where the public can access everything from contraception to antibiotic prescribing, and it's serving as a real alternative to alleviate those pressures both on general practice but also our emergency department. And I'll leave it there, Chair. Thank you.
Thank you very much, Sam. Open now to questions and comments. Sir Palihungan. We're resuming the meeting of the North East and North Cumbria Integrated Care Board, 30th of September 2025. We had a technical problem which has now been resolved, and we're returning to discussion of the Chief Executive's report. She gave her report, and we're now picking up questions and comments. Sam, could you just remind us what we were discussing when the technology failed?
Yes, thank you, Chair. Sir Palihungan, one of our non-executive directors, asked me the question with regard to the National Neighbourhood Implementation Programme, what funding had been made available for the two sites, and my response was that whilst there is no actual money that's being invested to support delivery of the model locally, the national programme does give each of the sites access to coaching and improvement support and the ability to join a national community of practice. I think the expectation very much is that the resources that are currently funding aspects of neighbourhood health would be utilised to develop and build the new model. I think we are realistic about the need to explore how we support all of the sites with regard to the development capacity and support, and both from a personnel perspective and a funding perspective. And I think that will be very much a live conversation as we progress through this.
Thank you. And are there other questions and comments on Chief Executive's report that anyone would like to raise? No. Sam, I just wondered if we could have a little bit more clarification on the present status of the reorganisation of integrated care boards across the country, because we haven't said too much about it in the public meeting so far, but it's quite a technical subject. But essentially, for those who are not familiar with the changes, we're required by national NHS policy across the country to reduce the size of integrated care boards by 50% in order to release savings for frontline care. And in addition to that, our role is being streamlined and our role rebalanced relative to that of the regional office of NHS England, which eventually will become the regional office of the central government Department of Health and Social Care. But at the moment, integrated care boards across the country are having to hold back on the changes and release the savings because of uncertainty about how redundancies will be funded. So, Sam, I just wondered if you could, again, just summarise where we are and give a feel for the scale of savings that might be realised once these changes have been implemented.
Yes, thank you, Chair. So just a really brief recap, building on the points you've already made. So we were ready to launch our consultation at the beginning of July with our staff, thanks to the work, significant amount of work under Jacqueline's leadership as SRA for the programme had been undertaken. But inevitably, with making such a significant cost reduction to the organisation, when most of our funding does go through running costs, goes on people, there are inevitably redundancy costs involved, which we estimate to be approximately £10 million in total. The board will know that as an ICB we have a statutory duty to break even every year, so the way in which we fund this would either come from underspends in budgets or stopping doing something else. And of course our budget goes on commissioning health services for our population, so not easy decisions to make. So along with the other integrated care boards in England, we've been seeking guidance on how to get both the approvals for a redundancy scheme and the funding to meet those. At this point in time, if we enacted a redundancy programme and delivered the savings, the cost benefit would be just under £1 million a month. So every month we delay this programme now, we are missing potential reduction in costs of workforce of just under £1 million a month. Obviously, the payback for redundancy would be over a multi-year period, but it's enabling the headroom in the plan this year alongside managing the risk in the system on the finances so that we can meet our statutory duties to break even, which we are expected to do, which is preventing us getting this underway out with any further national guidance or support to enable us to do this. So the latest position on this from NHS England is they remain working on it, and we should expect some guidance imminently. I think for us as a board, whilst we haven't taken this decision yet, and it would not be my recommendation that we take this decision today, at some point in time we will need to take a view on whether or not we are going to be in a position to proceed this financial year, or whether or not we hit the pause button and wait until the following financial year. Like I said, I don't think we're in a position to take that decision today, and we should certainly give NHS England a further couple of weeks to hopefully provide us and other ICBs with the guidance required to enable us to enact the change that's needed.
Thank you. I think that'll be very helpful to those who are not on the board and listening to our business at a very clear and comprehensive explanation of quite a technical subject, but one which has a lot of implications for the amount of money that we can release onto the front line to treat more patients. Any comments or questions? Thank you. Well, thank you again for your report, Sam. We move on now to the item 9, which is the North East and North Cumbria Integrated Care Board Complaints Annual Report for 2024-25. And Claire Riley, Chief Corporate Services Officer, is going to present this.
Thank you, Chairman. I will take the paper as read. There's a few points that I would like to present to the board today. Just to confirm that from a complaints point of view, this report covers the complaints that the Integrated Care Board is responsible for, and those are primary care complaints and complaints linked to ICB business. This does not incorporate complaints within foundation trusts and providers of that nature. So I just wanted to make that clear. But this annual report provides a summary of complaints, concerns and issues for the period of the 1st of April through to the 31st of March 2025. And the purpose of this report is to provide the assurance that we have fulfilled our statutory duties regarding complaints management. You will see from the report that it's fair to say that it has been a developing team and a developing picture. And what we've had to do during last year and also the beginning of this financial year is really make some changes to the team to improve the work within complaints, recognising that from a fulfilling our statutory duties linked to responding within 3 days. With regards to ICB complaints, we are at 95.2%. With regards to primary care complaints, we are at 59%, and that was certainly the position up until the end of March, but I am pleased to say that that has improved significantly as a result of the changes that we've made to the team and the additional resource that we have put in. This is still a area of transformation. It does position where we were at a point in time, and I am pleased to say, linked to updates that we do take to Quality and Safety Committee, that we are starting to make some significant improvements in the performance of responding to complaints within the allocated time. I'd like to thank Deb Cornell, Linda Hutchinson and Rebecca Heron for the work and the intensive work that they continue to put into this area. A few other points that I would like to make with regards, you will see in the report, it highlights certainly for ICB complaints, 3/4 of the volume that come through linked to all age continuing care and also dentistry. What we have seen most recently is a bit of a reduction in some of the dentistry issues coming through, certainly from our key stakeholders, and we are confident that as a result of the work that's already been presented to board by David Gallagher, and we are hopeful that we will see that corresponding reduction in complaints too. And as the board have already heard with regards to all age continuing care, there's an awful lot of work ongoing in that area, and we would hope to see a reduction in the complaints coming through in those areas over time. Otherwise, I am happy to answer any questions, Chair.
Just to add before others come in, Claire, that this was an area that when we took over the work of the 8 clinical commissioning groups, there was quite a backlog of complaints to be worked through, which took a considerable amount of time, and now we're we're almost through that process, aren't we?
Yeah, so there were a number of different processes that we've had to merge. Alongside this, we also took responsibility for the primary care complaints, and of course what we've had to do is relook at all of the different processes and bring them into one team and get them working as one team as well. And actually I'm pleased to say that that's certainly making inroads, certainly in this year, Chairman, and we're seeing significant improvements and a reduction in the backlog.
Yeah, and I think just to add, I've been and the Chief Executive have both been involved in talking about this and finding out the best way to deal it. And it is frustrating for us sometimes to see how distressed complainants are, particularly with very complex clinical complaints or complaints about very complex clinical care matters. And I think it must sometimes feel to them as if we're not energetic enough in investigating them, but there is absolutely no sense in which we're trying to rebut any complaints. We want to get to the bottom of things and give people a clear explanation and also learn as much as possible from what's happened. But it is extremely slow process sometimes to get all of the clinical expertise together that's necessary to make a proper judgment on, and a fair judgment on the care that was provided. But it's certainly, as you say, something where we're not seeking just to improve the delays, but we're seeking to improve the core process itself so that we're able to satisfactorily resolve as many of the complaints as it's possible to do so.
I agree, Chair, and what we're keen to do is really get upstream. There's a lot of intelligence that comes through the complaints process, and what we need to do is how do we use that to actually transform services as well. And there's a lot of work to be done in this area, but there's also some transformation too. I would argue that overall from a complaints process, we are still quite outdated if you compare us to other customer service organisations, and we have a lot of work to do across the NHS in this area, and that's something that is absolutely on our radar, and we are looking at some developments on our website which will streamline again some of the complaints process too for those users who are sharing information through that process.
And as Chair of the Quality and Safety Committee, Sir Pally, did you want to add anything on this subject?
Well, one of the items that we were going to refer to is specifically along these lines. We received the report that has been presented here to the board, and I don't think I need to add to what Claire has said. What I will say is that we had a case history, a lived experience of a person who, for medical reasons, required several admissions to hospital and to care facilities in one of our localities. And the relatives were keen to find out why there had been delays and difficulties in organizing this patient's care. And the case history showed us that at a very local level, this is as opposed to the macro level reporting at ICB level, we learned that it's frequently the case that there are delays in responding to complainants' concerns. These problems may well be related to difficulties in communication or the presence of appropriate people at appropriate times. I feel that if we're going to improve the situation in response to the complaints factors, we probably need to drill well down into very local mechanisms and see how those can be supported to make them better, more efficient and faster. I think delaying responses to people who are uncomfortable with what has happened just makes things worse.
Thank you. Ken Brimner.
I made a couple of comments at the committee where this was discussed originally, I hope Claire's picked them up. One was to make sure we've got a clear, explicit statement of the statutory responsibilities of the ICB in terms of complaints. And it may just be the 3-day acknowledgement is a statutory responsibility, but that needs to be explicit. The second one was a little more context, perhaps in future reports, of on the rate of complaints. So, for example, if you look at primary care, and it mentions 900 and whatever it is, 45 in the report, in isolation, that looks like a big number, and each one of those is very valid, and something can be learned from them all, I'm sure. But actually, against the total number of primary care activities that we see or contacts we have, it's probably infinitesimally low. So maybe a little bit of context around some of the numbers next time would probably be helpful as well.
Yeah, just to respond to that, Ken, and it was a really helpful challenge at the Quality and Safety Committee. And what we're working on is a comprehensive tracker and dashboard, which will allow us to do exactly that.
Thank you. Any other comments on this? Thank you very much then. We've received that report with interest and commitment to further improvement in this area. And the next item is also yours, Claire, item 10, on standards of business conduct and declarations of interest, our policy in that regard.
Thank you, Chairman. Hopefully this paper is self-explanatory. It is an updated policy, and it's specifically as a result of some changes from a procurement point of view. You will see that the procurement pro forma is no longer in use, therefore the policy has been amended to reflect that. Reference to NEX has been deleted, so the North East Commission and Support Unit, because the procurement team actually were transferred into the organisation, and procurement guidance has been added and the appendix has been amended accordingly. Happy to answer any questions, but we are seeking approval from the board for this policy.
Okay, are there any questions? And are you happy to approve this? Thank you. Moving on then to the reports of the committees of the board. So we start with the report on the executive committee that's chaired by our Chief Executive, Sam Allen.
Thank you, Chair. I'll take the report as read. Just to pull out a couple of points, really, and the minutes in the report relate to the July meeting. I just want to bring the board up to speed with a couple of things we've taken through a more recent meeting as well. So I've already touched on the ICB approach to medium-term planning that's expected of us. To develop a nice 5-year strategic commissioning cycle, and we've got work underway on that. I would definitely certainly welcome comments from the board today on the way in which the board would like to be involved in that, and we can obviously utilise our board development sessions as well to support that particular piece of work. The strategic approach to clinical services framework. So this is an area of responsibility we delegate through the provider collaborative, and the committee did receive a comprehensive presentation on the work undertaken to date, and I think the reflection of the committee was that the work could benefit from some time from the whole board. So we have scheduled that in for an October development session, and then delighted that Mike Smith, member of our board, brought the strategic principles for artificial intelligence in health, of which we signed off, and the aim of these is to provide a consistent framework, particularly to support coherence around the use of artificial intelligence, which is moving so fast, and we're seeing different parts of our system adopting different bits of digital technology to support this, and obviously we want to maintain some coherence with this approach, maintain ethical standards, and also ensure that the adoption of this tech doesn't worsen our issues around interoperability, but also strengthens it as well. So we'll be working on the communication of that, and Mike, you may want to say a few points on that as well. And then just finally, I did just want to bring to the committee's attention, we took a decision at the committee in September to develop a single prescribing outcome scheme for the North East and North Cumbria. Historically, these have been set and negotiated at a local level. We as a board signed off on our medicine strategy earlier this year, and a key part of that is aligning incentives for prescribers to particularly focus on key clinical conditions. We also want to reduce the amount of administrative burden and bureaucracy, particularly for general practices, and the committee agreed that we would not be reducing the financial value of this, but we would be looking to standardise the approach across the North East, North Cumbria, and our medicines optimisation team will be working with colleagues in primary care to implement that over the forthcoming weeks. Thank you.
Thank you, Mike. Did you want to add a thing on the artificial intelligence?
I'm happy to answer questions, Chair, but I think Sam's summary was pretty spot on, really. Yeah, so what we've developed is a single page set of 10 principles that we want our providers to conform to when it comes to artificial intelligence. They're quite flexible, recognising the fast evolving space, but it is about just maintaining those absolutely core principles that we have.
I think a quick observation I've taken, as I know that Sam has a great interest in this and Mike has, the area that I find that I've been discussing most when I've talked to doctors and other people working in the health service is the potential for improving the record of the consultation. I'd be interested to see whether you or Neil have any thoughts on that, because I've had a long-standing concern that in the pressure of work, both in primary care and hospital, you do get a record, but it's not complete because there isn't the opportunity to bring in everything. But in some of the settings I've talked to, with the patient's agreement, the doctor has recorded the consultation on an audio recording, and then immediately artificial intelligence has produced a comprehensive record of the consultation, which picks up everything, including things that sometimes seem peripheral, but they're all included, and the patient then signs it off before. So far from people speaking to robots, which is the way this is often sensationalized, this is an enhancement of the partnership between doctor and patient, and then it greatly improves the opportunities for continuity of care, because the next doctor, if it isn't the same one seeing the patient, hasn't just got a handwritten note or a typewritten few lines, they've got a whole assessment of what happened. I think it's a major step forward, but I'd be interested whether I'm just getting over enthusiastic about it. Mike.
Thanks, Liam. Yeah, so I mean, it's really exciting, and these are recording consultations, making notes is not something anyone goes into medicine or care to do, because it's pretty dull for the most part, but it's necessary, so everyone's learned to do it and everyone does it. So taking away some of those relatively tedious administrative tasks gives more time back to spend with patients, but it also, as you say, has the opportunity to improve the quality of the notes. It's not the panacea, though. It creates a few problems as well as benefits, in that once the notes get significantly longer, then reading them takes a lot longer as well. So it then sometimes increases time in other parts of the consultation where you're trying to understand what's happened before. It also, one of the benefits of making your own notes is it stores the memory of what happened in your brain a bit more concretely, and having a machine do that takes away some of that human element and that human memory that you create. So there's definitely some slight negatives that we're learning to navigate, but I think the overall potential is enormous and the benefits are there. Lots of general practices and some secondary care organisations are already starting to pilot and introduce this technology in the region, so that is already moving at pace, and we're just trying to support and make sure that's developed and rolled out in a way that meets everyone's needs.
Neil.
Yes, I would agree. I think it is an exciting opportunity to record more usable information. I think a lot of clinicians are still quite sceptical about the ambient voice technology, which is what you're talking about, where the AI listens to the consultation and then produces the clinical note. But as we get more experience with it and more confidence in the technology, then I'm sure it will be more widely adopted. I've personally started using it as a dictation. I'm not a great typer, but it's really sped up the amount of information that I record and the time it takes, and it can also automatically generate referral letters from the information I put in. So there's actually an opportunity to use the technology in a limited way, which improves my productivity as a doctor in the consulting room. So that's welcome for many, I'm sure. But I think it is an exciting time, and we'll just have to see how it develops over the coming months.
Pally, any thoughts from you?
Yes, I think the next stage in that, as I look at my primary care colleagues, is for the recorded consultation to be tied to a clinical diagnostic system, which may flag up potential diagnoses that the doctor may not have considered, or the nurse or the healthcare worker. In particular, we as clinicians tend to work to a set of diagnoses that are more prevalent in our minds, and the rarer, perhaps the less considered items tend to get missed out, and the advantage of direct transcription into a diagnostic model offers the ability to make a more accurate earlier diagnosis, particularly around undifferentiated symptoms.
Claire wants to come in. I'll just make one more point. I'm conscious it's a bit of a pet subject of mine at the moment, so I won't bore everybody, but I do have one little theory which I feel very strongly about, and not everybody seems to latch onto it, but essentially a consultation involving the doctor and the patient's story, which is at the heart of getting to accurate diagnosis, isn't usually given in a linear fashion. And I can remember some of my early work in getting patient feedback on consultations, that one of the biggest difficulties the patient had in those days, maybe times have changed, but was that they became tongue-tied during the consultation and didn't feel that they came out not feeling that they got their points across. So what the AI can do is it takes quite, if you like, a disaggregated conversation, not in an orderly way, into a proper linear account, which is essential, in my view, to getting the right diagnosis. So that would be just an additional point to make. But Mike.
So just to respond to Sir Pally's points about the bringing that kind of diagnostic sort of second pair of eyes, I think is a way to see it. We are within secondary care across several of our providers in the region that already is in place for radiology with chest x-ray reporting. We've got a product that we use that essentially will spot things that may have been missed on a chest x-ray, providing exactly that sort of model of not taking over the diagnosis, but giving that extra helping hand. And Salim, I agree that trying to pull all of that information, and it's not just from what the patient's reporting, it's also their long medical history, which now runs to hundreds of pages in a GP record. Trying to pull out the key pertinent facts to help bring forth the diagnosis is going to be so important. Sadly, the tech's not quite there yet, but we're getting close.
Thank you, Claire.
Thank you, Chair. Mike kindly presented to the Joint Overview and Scrutiny Committee yesterday for the North East, and there was a huge amount of interest actually in this subject with some really interesting questions. And I think as part of this, and recognising there's been an announcement today regarding an online hospital, we must bring the public and the patients with us on this, and we have a lot of work to do to make sure that we openly communicate and we allay any fears around data and things like that, but we also build trust and confidence in the NHS services of the future, and there's a lot of work to do around this area.
Thank you. That's an excellent executive committee raising that important subject, so thank you very much. So over to the Quality and Safety Committee, your meeting on the 10th of July, Sir Pally.
Thank you very much. The first 2 points on that slide I think we've covered already in our previous discussion. It's to do with complaints, and I mentioned how we learned from lived patient experience and complaints. On the other 2 points on that slide, I just want to highlight an item which is a regular one for us. This is not a criticism, it's just a note of the fact that our hospital-acquired infections continue to rise. This is a national trend. We're no exception to this. And in addition to the usual bugs, we've now got increasing and rising rates of both MRSA and C. difficile. I know that ICB-wide measures are continuing, and I'm satisfied from the point of view of the Quality and Safety Committee that the trusts are doing what they can, sometimes within certain constraints. So I won't comment any further on this except to highlight that. And finally, medicine shortages. We were made aware at a previous meeting of a national situation in terms of supply chains and the supply of medications to pharmacies, retail pharmacies. And we felt that this was an important quality and safety factor. And I'm very pleased that our colleagues working in the medicines side of things produced a brilliant report on reasons for ongoing medicine shortages, often very patchy, so that something might be available in one pharmacy and not in another a short distance away, and we needed to know why this was the case. Particularly in difficult areas, rural areas, where patients may have to travel some distance to get their medicines only to find that they weren't available. This is a big national factor, and it has a lot to do not just with local distribution, but with the availability and supply of medications at a national level, across international borders sometimes. There are also factors concerned with reimbursement and pricing, which may lead to factors at a very local pharmacy level in terms of purchase of drugs for keeping in stock. But the overall feeling was that it would be helpful if we as an ICB were able to highlight this to our colleagues in the Department of Health in a way that they would perhaps reconsider their overall national approach to this. And secondly, we wanted to commend our pharmacy colleagues for the efforts that they've been making in terms of providing an equitable service to all the patients that we have in our area. But this remains a live and worrying problem for us all.
Thank you very much, Sir Pally. Hilary Lloyd, our Chief Nurse, I know that you've been recently have launched some discussions on healthcare infection. Do you want to say a few words about that?
Yes, certainly. Thanks, Chair. We've since I've been in post here, we've discussed this just about every board, haven't we, around infection control and particularly healthcare acquired infections, whether that's inside hospital or within communities. And we are looking at how we can bring together like-minded people to really look at this really difficult problem in our region. We know that this is a national issue as well, and I've been in national meetings, regional meetings, and within the ICB as to how we look at this, potentially through a different lens, pulling in our public health colleagues and our local authorities to look at how we can really impact this in the community. And we've had a conversation about how we bring people together, hopefully very soon before Christmas, to discuss this. Thank you.
Thank you. Sam Allen, Chief Executive.
Yeah, thank you. I think it's really helpful that the Quality and Safety Committee is particularly understanding the risks associated with the voluntary scheme for branded medicines, pricing, access and growth. And of course, this is a national issue. I wonder whether or not we need to look at doing a piece of work with the Finance Committee on this, Pally, because particularly setting our plan, we have to develop a 3-year plan. We know that we spend about £1 billion on medicines across the system. So whilst there's a sort of supply and access issue that we're experiencing out with our control, because some of this relates into sort of global and more geopolitical issues, but actually where we need to, what the level of financial risk is that we need to plan for and prepare for. And at the moment, I think probably we would only be able to put some estimates on that, but I think this is a growing and significant risks for all funders of healthcare in the UK, and I think it would be helpful if we started to really understand the materiality around this and then the implications for future commissioning.
Thank you. Any other points anyone wants to raise on this item? Okay, thank you very much. Sorry. On now to the Finance, Performance and Investment Committee, and Dr. Mike Smith is going to take us through this.
Thanks, Liam. So there's no minutes in your pack this time because the only meeting since our last meeting has been the September meeting. The minutes will be ratified in the next meeting and provided to the next board. So this is a summary of the points that were discussed. I'm not going to go into a great deal of detail on any of these matters because they're almost all on the agenda today for the main board. So David provided an update on the finance position at the time, which we went into in great detail, and we also received an update on the Financial Sustainability Group and their work. From a performance perspective, we received a deep dive into community services, which was an excellent report, and we're all about to hear shortly, so I won't go into detail on that. And it's the same is true of the integrated delivery report, which is a more extensive version this time around. Some of the key points from that were drawn out, but again, I'm sure Jacqueline will detail that today. And we also received the risk register for assurance. Thank you.
Thank you, Mike. Any points or questions anyone wants to raise on that? No, thank you. As you say, quite a lot reflected on other parts of the agenda. Moving on then to the next item, item 13, and David Chandler, Chief Finance Officer, is going to give his finance report. Have I missed something? Yeah, I'm sorry. I've skipped over the integrated delivery report, item 12. So that's Jacqueline Myers, Chief Strategy Officer.
Thank you, Cillian. So first of all, I'd just like to take you through a few headlines for the formal August data publication for performance and the integrated delivery report that's included in the pack. So just to draw out some key headlines, and as ever, happy to take any questions. The data in this report for urgent emergency care, which relates to July, shows a really positive position. Really nice to see overall across the North East and North Cumbria our 4-hour performance exceeding 80%. Our category 2 response times for our ambulance service still remaining strong, and although not yet established as a kind of a stable trend, a good position that exceeded our own plan in terms of the number of patients who waited over 12 hours in department at 3.4%. When you dive into the report, you can see that nationally that's still running at 7.5%. So generally quite a positive performance there. Bit more concern to be drawn to the cancer performance. So this is the standard that anyone referred to hospital as an urgent suspected cancer should get seen and have treatment established or a benign diagnosis established within 62 days. You can see there it's at just short of 66%. We are concerned about this. There are a number of factors driving it, not least some of the impacts on the breast cancer performance as a result of the well-established issues in County Durham and Darlington Hospital, which has meant that significant numbers of patients have had to move to other providers while those issues are dealt with. But in addition, we are seeing some pressure on the skin cancer pathway and also the urology pathway. We've got a couple of trusts who are in formal escalation around their cancer performance, but in addition, we're sponsoring some work on both the skin diagnostic pathway and also the urology diagnostic pathway, and we hope to see some positive impact on performance as a result of that. Just to move on to the elective 18-week position, pretty strong position reported here. We're trailing slightly behind our own ambitious plan, but we are still amongst the best in the country here in terms of that complete standard that's been monitored. So the number of patients who on the active waiting list who are under 18 weeks. The item of concern I wanted to raise is around the 52-week position. So we have seen really good improvement in the situation in relation to patients waiting over 52 weeks, with the numbers dropping by 40% in the last 12 months. But improvement has stalled over the last 2 or 3 months, and we have seen this pattern before where we've made really good progress, but the tail end of the waiting list has proved very stubborn to completely eliminate. And our Chief Exec referenced the letter we've received from Sir James Mackey around in-year performance and the fact that the issue of over 65 weeks is having to be resurrected and performance managed. And the letters stipulated that these weights, again, we should have a push to eliminate them by 21st of December. We've only got 2 organisations who have a challenge around 65 weeks, but suffice to say, we're continuing to do very detailed work on a pathway by pathway level with all of our providers who've got these longer weights still occurring. We've already received some recovery plans around delivering that elimination of 65-week weights and a return to the plans we set for continuing to reduce weights over 52 weeks. Just to draw a couple of other, if you like, areas that are highlighted as red on the action card, but I will leave aside the community weights because I'm going to present the deep dive shortly. We have had a look at what's going on with virtual ward occupancy. I think largely what we feel here is that Trust should have perhaps taken the opportunity to have a seasonally adjusted bed plan for virtual wards, because it seems to reflect lower demand during the summer period rather than a kind of falling off of use of these facilities. And we have a couple of times in board discussed the ongoing failure to meet the national standards around the efficacy targets for talking therapies for anxiety and depression, the reliable improvement, to get my teeth around that, Chair, and reliable recovery, where we're still failing to meet those on a consistent basis. And I've reported previously that the intention there is, through our commissioning powers, to try and ensure that as we expand access to these services, we stipulate a better performance from an efficacy point of view with those providers that we either continue to commission with or whom we make available additional contracts to expand provision. In this report, as my colleague Dr. Smith just mentioned, you've got the biannual performance highlights around the improving population health and quality and prevention. And for the first time, we've provided a scorecard in that regard on page 199 of the board pack. So there's quite a lot to be pleased about and to celebrate in here. So particularly when you look against the national benchmarks, we've got some real positive performance for our population in North East and North Cumbria in relation to MMR vaccination rates and in relation to the management of patients requiring lipid lowering therapies or management of hypertension. So some real positive indications in here. I think perhaps the area that we draw attention to, and I'm sure our Healthier and Fairer committee is focusing on, is where we still are highlighting significant inequalities. So whilst the headlines may look good, when you dive more deeply into, for example, related to myocardial infarction or stroke admission rates, we've got really significant inequalities, which obviously are deep-seated in terms of the health of our population, indeed in earlier stage cancer diagnoses. And the focus of our programme obviously is to identify targeted interventions that can start to close that gap. A good example of which would be our targeted lung health check programme, where we've very much focused that in our most deprived communities. And so others may want to comment, but just wanted to draw attention to that dashboard. And then if I just turn to the slide that you've got up before you on the display there, what we're showing you there is the kind of more, oh, we've moved on, can we move back, sorry. This is just, as I often do in board, the more up-to-date data. So since the report that's in the board pack was published, we've had a further publication of data in mid-September. I haven't got a lot to draw out here. It's really a continued position from what we saw in the August published data. Probably the 2 things I just draw attention to is that there is a significant improvement in the 62-day cancer performance from that sort of 65.9 up to 69.7, so a big step up, and most of that is to do with an improvement in the breast cancer position, which we're pleased to see. We actually saw, while we saw a continued strong performance on urgent emergency care, a slightly worsening of the position in August, but still holding strong in terms of the national benchmark. So I'll pause there, Salim, in case there are any questions before I move on to the deep dive. Thank you.
Any questions so far? Yes, please, Pally.
I'd just like to make a comment. I'm delighted that our MMR, which is the measles, the vaccine rates are good compared with the national average, which is only 84.5. Ours is 90 plus. Nonetheless, that means 1 in 10 is not vaccinated. Measles, mumps, rubella. I was it occurred to me, considering various discussions we've had today, whose responsibility is this? Is this public health? Is this primary care? And what are we doing to try to improve this even further, considering that there has been a rise in measles over the last year or so?
Well, I've had some behind-the-scenes discussion about this at various times, and I'll ask Jacqueline to clarify the accountability. But you're quite right. Although we score highly nationally, we're below the World Health Organization level, which leaves us at risk of an outbreak. And the methods for raising the coverage are not, in my view, taking advantage of some of the more modern thinking, where the focus isn't on coverage rates initially, it's on missed children and finding out why the children have been missed, and then using what internationally are called social mobilization techniques to correct that. So I think we can be more innovative in the methods, but we haven't been in sole charge of this over the last few years since we were formed. But I think Jacqueline can tell us what the present position is, and then I think we're going to have a more substantial role in this.
Yeah, so I might defer to my colleague Neil O'Brien to comment on this because he's the exec lead, but certainly it's an NHS responsibility rather than a local authority responsibility to ensure that our population is vaccinated for those vaccinations that are identified as part of the national programme.
So yes, the commissioning responsibility currently lies with NHS England. We obviously work in partnership with NHS England because it's of a vital public health importance for our population. The responsibility for the whole vaccination programme is planned to come to integrated care boards. I believe it's 2027. But we're already working very closely. We've set up local vaccination partnerships within all of our places that look at seasonal vaccination, but also increased uptake in the kind of standard vaccination programme. And I take your point, Liam, there is much further we can go. Our headline numbers look good, but we've got pockets where the uptake is poor. And we have used some of the insights around certain population characteristics that are more vaccine hesitant, and use things like trusted voices to get in and work with communities, increase vaccine uptake in certain cohorts like pregnant mums. And we've had some success, but there is much more we can do. And whether or not the change in the commissioning responsibility in 2027 allows that to be more streamlined or not, I'm not sure, because we already still work quite well with NHS England. But yes, more work to be done. But yeah, I take your point.
There is a fair amount of opinion now internationally that the anti-vaccination movement fueled by social media will escalate quite substantially. So we need to really get to grips with, I think, the root causes of vaccine refusal and so-called hesitancy. And yeah, Sam.
I just wanted to highlight an area that in the Executive Committee we're starting to focus on and seeking to understand is the figures associated with screening uptake. So we know that, early diagnosis, can make a tremendous difference to people's outcomes, and yet our screening uptake for breast cancer screening was 16.5% and bowel cancer screening 15.6%. I think, the variation in it, but I think we still recognise there's some areas for room for improvement in that. So both in the way we present the data, but also kind of getting underneath and understanding it, particularly for population areas. So we'll be focusing much more on that as well.
Eileen Kaner.
Just returning to the vaccination issue more sort of generally, I mean, ultimately, vaccination is an interpersonal sort of interaction between a practitioner and someone being vaccinated, and you've pointed to attitudes and anxieties around vaccination. Clearly, kind of staff vaccination rates is really important when you're thinking about sort of, COVID, winter flus, etc. And so it'd be really helpful to understand where we are at the moment to do with our rates of staff vaccination.
Thank Neil, you want to take that one?
Yeah, we can pick it up as part of the work that we've done on the winter plan. We've actually commissioned some research to look at what works with improving staff vaccination, and that piece of work is concluded. It's part of our winter planning process. We've got all of the executive leads of our foundation trusts together, sharing that research, sharing best practice. We're obviously just starting the vaccination now, if you're referring to seasonal vaccination. We are as assured as we can be that we will get vaccination levels to the required 5% improvement from last year, which still falls short. But it is quite a tough kind of environment at the minute, with a lot of NHS staff, a lot of people who are actively refusing to have the vaccine. But we'll use the best research, the best evidence, and try and get those vaccination rates up. But we're too early to tell exactly how successful that's been.
Jacqueline, perhaps we should move on to your next phase of your presentation.
Certainly, thank you. So the next phase of the presentation is the deep dive into community waiting lists, and I think this is timely. It's an area that we've just slightly ahead of the kind of national focus in this year's planning round. We're focusing on through the winter and trying to understand better. There's a lot of information in the slides. We will circulate them. They are also in the pack, but I'll also try and rattle through, and then we can take any questions. Just to begin with, some definitions. So the community services data set is a provider data set, not a population data set. It's submitted by the 8 NHS providers who provide community health services. And it's important that I draw attention to that, because within our data set, as you'll see shortly, there's really significant group of patients who relate to a private provider who's headquartered in the northeast. And as we've dug into the data, we've seen that they're a big element of the growth in our overall waiting list in recent months. Also, it's important to be aware that the data set excludes quite a lot of our commissioned community services, because where we commission services from the voluntary and community sector, or indeed from local authorities, there isn't any current data set to capture that, and therefore that makes it difficult when we try and compare between places, where you might find in one place that a particular service is commissioned from an NHS provider, but elsewhere it's provided by another sector provider, and therefore you can't really compare apples and apples, as it were. But nonetheless, it's important to understand these data, and I'll take you through them in a little bit more detail. This next slide just shows you that this organisation, Connected Health, I believe they've just rebranded as Cora Health, if you want to Google them. Is a big element of the waiting list that we hold. So as at the end of June 2025, we have 94.6 thousand people on our community waiting list, aligned to the ICB, if you like, but 19% of that related to this organisation, Connect Health, and within that, 18.4k of people that they have on the waiting list aligned to the ICB. Only 9% actually related to North East and North Cumbria residents. I hope that makes sense. And as you can see, their waiting list over the last 6 months has grown by 55%. But again, there's not a disproportionate growth of North East and North Cumbria. So that's a big, if you're trying to understand why the waiting list that we report has grown so significantly in the last 6 months, it's the kind of expansion of this particular business that's headquartered. And then a sort of second issue worth noting is that we are seeing improved coding and counting and data completeness in these data sets. Unlike some of the other data sets, it's not had the 20-year scrutiny and kind of forensic checking that some other data sets have. And so, for example, one of our providers, Northumbria, has started to count 9,000 strong waiting list that they previously didn't register against this data set from May this year. And that's another reason why the overall list has grown. So just a bit of context there. This next slide shows you, if you like, by our 8 providers, the size of the waiting list. And interesting there to see that almost 30% of community waits are on the County Durham and Darlington Foundation Trust waiting list. again, to understand why this is, that they've got a relatively large community population. Also, perhaps compared to other communities, more of the services are provided by the trust rather than a kind of broader array of providers, some of which wouldn't count. It's important to note that as you can see, because they're the dark blue line at the top, although their overall list is growing, actually they're one of our best providers in terms of avoiding the very longest waits, which I'll show you. So although they've got a large list, waiting times are relatively good compared to the other providers. So the colours on this slide are not as helpful as they might be, so hopefully you can see this in your pack, but this is looking at the waiting list by service. There are 44 different service lines across the 8 providers in our community waiting list, but as you can see here, 64% of those waits relate to 3 specific services. So these are the big chunks of the community waiting list: musculoskeletal services, podiatry, and then physiotherapy. If you can see the slide, the kind of purple colour is adults, whereas the sky blue is children. The next areas are speech and language therapy and then rehabilitation. So you can just kind of see the sorts of things that are making up these community waits there in that slide. I'll keep trucking and move on. So this next slide just shows you how the waiting list is growing, but also in kind of waiting time bands. All you've got here is 3 bands. You've got the 0 to 18 weeks, then 18 to 52 weeks, and then over 52 weeks. So in essence, what this slide is showing you is that actually the proportion of the waiting list that meets the 18-week standard is improving. It's kind of gone from about 75 to 82% in the most recent data in this time series from back in January. But the small number of patients who are waiting over a year is a less a positive picture. It's doubled in that time, from around 800 to over 1,600. So that's obviously of concern and something that we're now taking significant action on. When we presented this deep dive to the Finance and Performance Committee, one of the challenges we got from our chairman is that actually even 18 weeks is a very long time to wait if you're in the community suffering, for example, from significant pain and you need therapeutic support from a physio, for example. So we've added this slide in, Mike, in deference to your comments, which gives a bit more detail about the waiting time. So you can see there the sort of 1 week, 2 week, 4 weeks and so on. So up to the purple band, all of those waits are under 18 weeks, and some interesting data for us to dive into here if we had more time, really just to show that we're starting to really analyse this now. And you can see there's the third provider from the left there, North Cumbria, obviously would be an area of concern in terms of their significant number of 18-week to 52-week waits, and then also their over 52-week waits as well. And I mentioned earlier County Durham, you can see pretty positive performance there in terms of fairly short waits, but a number of the providers having a decent performance in terms of the proportion of their waiting list that they see within 4 weeks, which is interesting to see. Just now, finally, just to do a little bit of a dive into the waits for children and young people, because when we segment the 52-week waits, it's really children where the waits are starting to escalate. Now we've had a really good look at these data, and obviously that's of concern. So this graph just shows you the dotted lines are the plans. So blue is a dotted line plan, solid line actual for adults, and the orange is for children. So you can see they're significantly off plan for our children's waits, and lots of work to do to understand exactly what's going on here. One of the factors here seems to be really significant escalating demand in relation to neurodevelopmental pathways. For under 5s, those are in these data, and it's not just the neurodevelopmental diagnostic pathway, but the subsequent referrals to other services once the diagnosis is given, for example, speech and language therapy and other children's services that are under pressure. So some work to do here to improve children's waits. And this slide just shows you where the pressures are on the left hand side by service. So this is just the children's waits, with the community paediatric service, occupational therapy, podiatry, wheelchairs being the kind of key areas. I mean, this is really of concern, isn't it, that we've got children waiting over a year to access some of these services. And then on the right hand side you have those waits by organisation. So you can see that 3 organisations are contributing to those 52-week waits, Newcastle, North Cumbria and North Tees accounting for 90% of the over 52-week waits in our patch. So some concentrated work needed there. So to conclude, Chair, just to say we do have some significant risks around this data set in terms of setting an improvement trajectory, largely that we think there's still significant work to do to make sure we're capturing absolutely everything from a data quality point of view, and we've got really growing demand in the children and young people's neurodevelopmental services, as I just mentioned. We're also seeing rising demand in some of the musculoskeletal services as well. I think we've identified that our trusts perhaps have given priority to the secondary care 18-week waiting list, and many of these services are subject to a block contract and don't have the benefit of a income stream such as the elective recovery fund that's made available for the secondary care services. But certainly giving more attention to it and making sure that we've got granular recovery plans for the specific pathways that are under pressure, we think can make a difference. So just to summarise the actions that we are taking to try and achieve reduced waits in this area, a number of our local delivery teams have invested in additional musculoskeletal work. We're also participating in the Getting It Right First Time programme in relation to that. We've started to use our Living and Ageing Well programme board to draw attention to these community waits. And we've got, as you can see there, I won't run through them, a number of other specific recovery areas, including the system-wide ADHD and autism transformation programme, and some of the work under the service reform group as well. So we'll continue to keep a close eye on this, but as ever, I'm happy to take any questions. Thank you.
Thank you. Will, under the new arrangements for the organisation of the NHS, will it be foundation trusts in the future that commission these services?
Possibly. We still haven't got the guidance yet for how, if you like, the 10-year plan will be delivered. So we're hearing informally that there may well be kind of integrated health organisation type contracts that require a provider, possibly a foundation trust or possibly another, to take a kind of responsibility for a population's health and be the lead contractor for all of the needs of that population underneath, but we haven't actually seen the proposed framework for that yet.
Okay, thank you. Pally.
Could I ask for some clarification, particularly in light of the very immediate conversation you've just had? If we say, for example, that there is a greater need for earlier MSK musculoskeletal services, what's our role as a commissioning body in the future to do that? Because you've just mentioned that some of these services are commissioned by trusts themselves. So what's our role here in terms of an overall performance assessment?
So, as I said, Sir Pally, we haven't got the guidance, but I guess we would still anticipate in whatever framework exists that we would have the ability as a commissioner to commission outcomes. And those outcomes might, for example, be that people with particular clinical conditions were able to access particular services within timeframes. We might well set quality standards and so on. So it may be less about us choosing which specific provider or which location or which approach is delivered, but we shouldn't necessarily, I don't think we're concerned that we wouldn't be able to specify outcomes in that way in the future.
So we'd be the commissioner of commissioners in simple terms, I guess. John.
Yes, thank you, Chair. So I'm interested in some of the growth in children's weights, and I know within my system we're looking at, or we have in place a recovery plan around long waits in terms of neurodiversity and assessment timescales. And that clearly is multifaceted because there's significant work in prevention and around the system change and flows into demand. But what we also clearly have, and I'd be interested in understanding the thinking around some of this, is a mismatch between commissioned activity and current levels of demand. So if we're looking at how you reduce over time long waits and waiting lists, but we have commissioned activity of 75 assessments a month, but demand is 100 assessments a month, then clearly those waits are just going to continue until we get to a stage where the prevention activity starts to impact. So it'd be interested to understand how, and it does come to the complexity of commissioning arrangements as well, that has been referenced already, how, if the position is that the SEB as Commissioner of Commissioners is looking at that mismatch in some of those areas where long waits are happening, how do we start to address some of those if commissioned activity continues to be at a lower level than demand?
Thanks, Sean. I mean, it's a real challenging question. I appreciate it. I think, and I think just for clarity, you're probably referring to the overall challenge in neurodevelopmental waits, which is largely outside this data set, because this is just the 0 to 5. So what we're facing both locally and nationally in relation to neurodevelopmental services is an increase in demand by many times over. So maybe a 4 times increase in the demand in the last 10 years. And I think increasingly the view locally and nationally is that where you see such a fundamental shift in the demand, you also need a fundamental shift in the response, and the old model needs looking at. So it's not just a case of commissioning more volume through the same pathway, but looking at what that demand now is. Is it the same as it used to be? Is the same response required? Because it's not just a case of making a decision as a commissioner to fund a response, but it's actually how you then create that capacity and are able to deliver it. We are, as I mentioned very briefly, developing a comprehensive transformation programme for ADHD and autism services, and I expect we'll be bringing that back to the board in coming months, John, which will address some of those issues. In the short run, we have actually quite significantly expanded capacity in those services over, repeatedly over the last 3 years, but it's quite clear that we're running and not catching up, and there, in addition, potentially are some quality concerns about that rapid expansion of the service within the current service model. So I think it's a fair question. The answer is not straightforward, and I think we'll need a multi-pronged transformation programme in order to respond to it. Thanks. Mike Smith.
Thanks, Jacqueline, for an excellent report. I think these deep dives show to me the danger sometimes in trying to reduce an incredibly complex system just to single numbers, like the number below the 18%. The 18 weeks. In the slide that you've provided with the multiple coloured bars, you could look at County Durham and Darlington, for example, that show very good performance in terms of the number of patients waiting less than 18 weeks. But bear in mind that 18 weeks is a very long time to wait for. If you've had a knee injury and you need some physiotherapy, 18 weeks is probably to the point that it's actually going to be better by itself, and the chance of speeding up your recovery has passed because you've healed. So actually the 18 weeks in this line is possibly not a very good line, but actually if you look into the detail there, Gateshead, which comparatively look worse for the 18-week performance, are actually very good for waiting less than 4 weeks, which is probably a more useful line to set. I think it just shows the value of having a data and insights team that are looking into this and digging into that fine detail, because we need to look into the fine detail, because that's where the important changes need to happen.
Thanks, Mike. Yes, Sam.
Thank you very much, and thank you, Jacqueline, for the presentation. I think it's really good that we've now got good visibility across community waiting times. We haven't had that previously. Perhaps just building on the point that Mike has done, I think for us really getting underneath what the drivers are of the performance will be really helpful. And I'm just mindful of the focus around the acute services clinical strategy as well. So we know the North East, North Cumbria, majority of our community services are provided by our foundation trust, who also provide hospital-based services. And I think getting underneath what the driver of some of these waits are, is it demand? Is it workforce gaps? Is it differentiation in practice? I'm really interested in what Gateshead is doing. Where can we learn that's doing this well? And do we get underneath this? Because I think that will be important information to help support future commissioning intentions.
Thank you, Sam. I agree. I mean, in the interest of time, perhaps I won't respond in detail, but I think also as commissioners, we perhaps haven't always taken the opportunities to think about being clear about what it is we want to commission in relation to these services. I mentioned that most of them are subject to the block contract. There is some national work going on looking to unbundle and rebase community services, contracts and activity, which I think will be quite helpful in this regard.
Thank you. Thank you very much, Jacqueline, for the report and the deep dive as part of it. That's very informative. Thank you. We move on now to the finance report. Chief Finance Officer David Chandler is going to give that.
Thank you, Chair. So this is the report to the board that presents the month 4 financial results for both the ICB and the ICS. I'll take the paper as read as ever and just focus on the 4 main financial duties. So the first one is the ICS duty to achieve break-even on its revenue revenue resources. And as Sam alluded earlier, at month 4, on revenue, we're reporting as being slightly ahead of plan by £3 million or so. But that does include a significant land sale that has improved the position against plan by about £3 million. I would, though, however, ask the board to take note that the actual reported deficit, so not the deficit against plan, but the actual deficit at month 4 was £25 million. And that's significant because by year end, we need to recover that position. The month 5 figures weren't available at time of writing, but what I can share with the board is that the month 4, month 5 are relatively consistent in terms of where we are. Again, slightly ahead of plan. It's improved a little bit actually by £2 million, but the reported deficit is still there, and the plan is to recover that in the second half of the year. I'll mention efficiency because it's such a high figure. It's in provider side of the ICS, the average efficiency, and this is just the average, is 6%. And that's an incredibly high number and incredibly challenging to deliver in one financial year. And whilst providers are generally delivering at this moment in time efficiency numbers, what we can see is the recurrent side of efficiency is slightly behind plan at month 4, and at month 5 that continues. It's approximately £20 million behind plan at month 4. I would say half of that is what I would call as timing. So the plan is there and it will deliver, it's just not delivering as fast as we would like across the ICS. The other half is where there was a plan, but that plan is no longer feasible. And that's probably the greater worry for either that individual provider and the system as a whole. I'll touch on the deficit support. We have £33 million of deficit support funding for the system, which you'll all recall, if we don't achieve plan, we have to repay that back to NHS England. We've received Q1 and Q2. Based on the month 5 figures that I have seen and have been shared with NHS England, I'm actually quite hopeful that we will receive deficit support funding for Q3, which is £8 million. And that's not just good from a revenue point of view, but it's also good from a cash point of view. So, as I say, I'm relatively hopeful that NHS England will provide that to us in the coming days. In terms of the ICS duty, so the ICB duty to achieve its plan, which is our second duty, I can confirm the ICB is on track to deliver its financial plan, and the £9 million that we held as central risk, we're on track to deliver and manage as well. We do have some material adverse variances in programme budgets, which we will need to manage between now and the end of the year. They are, as we've just been talking about, in mental health within ADHD and ASD assessments. A few years ago, we spent about £2 million in this area in the independent sector under right to choose contracts. The current forecast is in the region of £25 to £30 million, which is extraordinary growth. And much of that activity is actually on the adult side rather than the children's side, and on the less severe clinically as well. And as Jacqueline mentioned, we are reviewing that both in the short term and medium term. The other pressure in the ICB is around prescribing. Much as the medicines optimisation team are doing really well in terms of delivering efficiency plans, we can see ICB growth in terms of items and the cost of drugs impacting on the plan, about £10 million of pressure or so, which we'll need to manage between now and the end of the year. And the last pressure that's directly impacting on ICB budgets is in all-age continuing care. We have an expectation from NHS England that we have a large efficiency programme in this area when we benchmark against other ICBs in the country. Good performance so far on the efficiency plan, but as Hilly would, I'm sure, share with me, it's a very challenging plan. It requires an awful lot of work and effort, and a big focus is ensuring that reviews are done within the time frame, as well as a few other factors such as reviews of one-to-ones and like. So there's an awful lot of reform work good in that space, as well as ensuring we've got the right staff in place in that area. As Sam also said, we are, wanting to implement a new structure. Our estimate around redundancy is around £10 million, for which we're yet to have a clear funding source from NHS England, but that is, as Sam has discussed, being reviewed. We are missing out on approximately £900,000 per month of savings by not being able to implement that, which is something which we'd rather sort of resolve sooner rather than later. In the report, I do include the underlying position. So as much as I focus on the ICB's position in year, it's important for the board to be aware of what is the underlying position. So I won't go through the detail of the calculations, but in short, the ICB has an underlying deficit. It's just the ICB of £25 million. And that's just where pressures such as an ADHD are going beyond what we've got set aside on a recurrent basis. And we'll need to manage that going forward into the next financial year as part of financial planning. In terms of financial risk, the ICB and the ICS, we are still forecasting that we will achieve plan. You'd expect that at month 4. As we roll into month 5, it would be a bit early to call it to sort of say that we were unable to achieve that. But we do have significant risk. The risk at the start of the year was £244 million. We have seen that reduced at month 4 to £170 million. So you can see that's coming down quite sharply. The latest review that we did with ICS Chief Finance Officers, as we went around the table and really dissected this figure, we believe the risk is in the order around £65 million that we really actively need to manage individually and across the system between now and year end. Of course, that'll be challenging. It's a large number, but I can assure the board that every organisation, the ICS, individually and collectively, we are working on ensuring that we can bring that number down as fast as possible. And indeed, we have a meeting, a workshop next week where we will look at what we can do, not just on finance, but on performance and workforce challenges that we have for the second half of the year. And that will help us provide assurance to NHS England as well. Third duty is around capital. I won't go into that in great detail because the current forecast is that we will deliver the capital plan for the financial year. On running costs, the fourth duty, we're holding so many vacancies in the ICB that I have no concerns about delivering that duty. And of course, if we have to incur any redundancy costs, I'd expect NHS England to take account of that in terms of that duty. Last thing I mentioned, Chair, is just around long-term financial planning. Whilst we haven't had all the guidance yet, or we haven't had allocations yet for the next 3 years, work has begun on that across the ICB, across the ICS. We will work with NHS England to be clear on roles and responsibilities given the changes that have been announced around that in that area. My expectation is, the next 3 years will continue to be incredibly challenging given the amount of growth that's been notified nationally, and coupling that with rising demand and inflation levels being high as they currently are. And the last thing is, I wish I could end up on a high note, but just to sort of say that we're very conscious that the left shift is extremely important. That will be one of our key roles as a commissioner in terms of developing financial plans. We don't have additional resources for that. There is no additional funding stream for double running or putting money into left shift. So we will have to do that from existing resources and find ways to work with partners to enable that, to make sure that we help deliver the 10-year plan in that left shift. And they're my key points, Chair, and haven't taken any questions.
Thank you. And just clarify left shift for people line who are not familiar with the term?
Yes, sure, Chair. So there are probably three aspects of that left shift that gets referred to as part of the 10-year plan. So, for example, that's moving from analogue to digital, so that we use less paper, we use digital devices, and we use the benefits of AI that we discussed earlier. Is moving away from sort of treatment to prevention. And care being close to home. So it's all those aspects of what was described as left shift.
Thank you very much. Comments and questions on the finance report? John Pearce.
Yeah, thank you, Chair. I'm interested in the reference to the national benchmarking around old age continuing care and sort of the underpinning basis for some of that. Does it take into account the correlation between what is a needs-led budget, demand for that, and the links to deprivation and our demographic challenges that we have in the North East, or is it a broader benchmarking that is based around population numbers, because it's obviously very significant in terms of some of those needs-led budgets?
Yeah, absolutely. So John, at the start of the NHS alluded to the fact that there had been some benchmarking exercise, but hadn't actually shared with us enough of the detail, more the headlines. The detail we have now in terms of how that benchmark exercise was done was looking at the proportion of spend of ICB resources on all-age continuing care compared to everything else that we spend money on. So in theory, it then does take account of demographic needs and the like, because our total allocation, it takes that into account as well, you know, if you work on the basis that the formula is accurate. Now, of course, what you need to bear in mind is, you know, every ICB may slightly have different ways of what they count and collect in all-age continuing care spend, but the actual figure that they've shared with us in terms of the proportion of resources that we spend on age continuing care compared to, say, the average ICB is higher than average. If I remember right, the figure was around £50 million. And we spend approximately £350 million in all-age continuing care, so about £400 million in all-age continuing care. So it's quite a chunky figure we need to look at. Now, we will obviously do the data review in terms of how accurate is that figure, but I think the headline message was that it looks like we're spending more money on all-age continuing care in North East North Cumbria compared to the average. And when I looked at the data, there wasn't really a correlation to say all of those in the north were spending more than those in the south. It didn't feel like that. Maybe a touch, but maybe not to the sense of that figure being so high compared to others. There was one ICB in the country, without naming them, seemed to be spending, in the north, it seemed to be spending a lot less. My instinct, that's probably a data quality issue. But to answer your question, it does take account of demographics, but it's quite it's quite a blunt instrument in terms of what we're spending. Because you have to remember, spending money in all-age continuing care isn't necessarily a bad thing. You know, it's supporting people to live in their own home, etc., and be treated for. So we've got to take these things with a pinch of salt, but certainly we do need to be ensured that we're as efficient as possible with that money we're spending, and we're clear that there are opportunities there.
Lisa Taylor.
Just a query around the three key shifts, especially treatment to prevention and hospital to community, or the other way around. A lot of that work will be supported by voluntary sector organisations, and as you've pointed out, there's no additional money within the system to support the left shift. And the voluntary sector, as you know, is in a pretty precarious position due to financial circumstances. What do you see the impact is going to be? Do you think that there's going to be increased reliance on the voluntary sector to achieve the three key shifts? And do you think that there's going to be enough money within the system to support the work that the voluntary sector will need to do? Or do you think that the ICB and NHS might lean more on the voluntary sector without the additional resources necessary to support it?
I wish I could answer that question really well. I think what you posed there for us, Lisa, is these are the challenges and considerations willing to take account in terms of how do we make the best use of what we've got, and how do we work closely with partners to if you like, increase productivity and get the biggest bang for our buck. So I don't think there is any short answer that can adequately answer your question, but they're the sort of considerations we'll have to give in terms of developing a plan. The other thing I would say is NHS England have sort of tried to differentiate between system, commissioner and provider, and I think what they want us to do is become more conscious of what we're commissioning and less conscious about how the financial system, which in the moment is ICB and Foundation Trust work. So in theory, there's some bedrocks have been put in place to enable ICBs to make decisions which are more closely related to the wider population than rather than also thinking about how that impacts just on the Foundation Trusts and the ICB in isolation. But there's no magic answer to that question, I'm afraid.
Just to clarify, if we have much more discussion, which we can, if we need to, we'll be deferring the next item until after the break, so that will lengthen the meeting. Claire.
Thank you, Chair. It was just to respond to that query, Lisa, and also to support what David Chandler has just said. What we've got to focus from a voluntary and community sector is look at the differential between grant and commissioned services, recognising that very often the grants are short-term and create problems within the sector. And you will recall the paper that we've already brought to board with regards to full cost recovery and how do we make sure that when we are commissioning services that follows through to voluntary and community sector organisations too. But I think the big focus with the voluntary and community sector is very much around how do we ensure we are commissioning those services as part of our strategic commissioning plan, as David has mentioned.
Okay, thank you. I can't see anybody else wanting to speak, so we move on to the final item before we break, which is the system winter plan for this year. That's Neil O'Brien, Medical Director.
Thank you. So I'm presenting today our system winter plan. This is the second airing that this has had at board, and we've got a particular ask this time in that by the end of this month the board needs to be assured that we have a sufficiently robust plan in place, and then we need to sign a board assurance statement relating to that, but I'll cover that at the end. So just a bit of a summary. On 6th of June there was a urgent emergency care plan published which looked at 7 key priorities, mainly around urgent emergency care improvement, around ambulance response times, the handover in ambulances, the 4-hour standard, 12 hours in A&E, treating more children within 4 hours, long waits for people with mental health problems, and improvements in discharge. And just to give board assurance, our plan is built from the bottom up and covers all of these areas. So our approach to winter planning this year is we set up a new group which is chaired by myself, the Winter Planning Delivery and Assurance Group, and it brings together our Living and Aging Well Partnership, the Urgent Emergency Care Network, and our LADBs. Remember, our Urgent Emergency Care Network is a network of our LADBs. That stands for the local A&E delivery boards, which are place-based boards which look and bring partners together from health, social care, primary, secondary care to ensure that they've got robust plans in place and iron out any local issues in the urgent emergency care pathway. This year, just to recap, we again have taken the approach of looking at some big priority areas for our system, and I'll not go through these in huge detail because we did that at the last board, and the details in your pack. But it's about enhancing the respiratory pathway, maximising the preventative and home-facing offer around care coordination, and improving in-hospital flow, and that is around ambulance handover delays, internal professional standards within our foundation trusts, and best use of same-day emergency care. And on the backdrop of that, obviously, really promoting our work on vaccination. Since the last board review of this plan, we have made progress. enhancing the respiratory pathway, we're looking at a proactive approach, something called Optimise, which is about identifying patients within our community who are at the highest risk of admission to hospital with COPD. And we were originally going to go out to offer this optimised programme, which is the proactive care for 50 of our practices, but I'm actually pleased to report that we're able to offer that to all of our practices, and we're in the process of just rolling that out currently. We've agreed a new process in place to meet the standards around the maximum 45-minute ambulance handover delay with all of our providers. We've also used the best research that we can, as I previously mentioned, about improving vaccination uptake in our staff groups. And we have agreed the proposed locations for over 40 acute respiratory infection hub sites across the North East and North Cumbria, so we can mobilise those services from late October. We also use intelligence as well, because it's respiratory illness that really puts the pressure on the urgent emergency care system in winter. We've used intelligence from the Southern Hemisphere and looking at the virus profiles, and got that information out to all of our providers as well to aid their planning. There's nothing to suggest that this coming winter will be any different to last. We don't think we'll have we had the quadruple whammy, if you like, last year of the strep infection, flu, COVID and RSV coming at the same time, which put quite a lot of pressure. We don't think that that's going to happen again this year, but the flu profiling from the Southern Hemisphere looks as though we'll have a similar flu surge around about late December, early January. COVID's too difficult to predict. It's still not that seasonal. RSV usually hits in November time. So again, we use this intelligence in our planning, and we're getting better at that. As part of the board assurance process, there is a checklist, and this slide just really highlights, and it's in your pack, that we have gone through the checklist, and our winter plan does cover all of the necessary aspects that should be required for us to sign this off at the board. The next two slides are specific around what the assurance statements are asked for within the within that document, and the actions that we have taken within the winter planning group in order to give the board assurance that we have this covered. I'll not go through each and every single one of them. They are there for your review, but we've done a quality impact assessment on our board. We've had our plan here a couple of times now. We've got wide system engagement through our networks and our LAD-Bs. So this, and we met with our directors of adult social care as well a couple of weeks ago. They're all assured that they feel well connected into our winter plans, both locally and across the ICS. We have been involved in winter exercises, both at the North East and Yorkshire level. There was an event in York, but also across our patch, because we've got quite a big patch. We've done some peer challenge from local A&E delivery boards across the patch. So I think we are in as good a place as we can be. So the board assurance statement, so it's really for the board to ask any questions, any final questions you have on our winter plan. Hopefully you are assured enough that we've gone through a robust process to get the plan in the state that it's in, and we're looking obviously now we've already started delivery of it, but we'll be monitoring that through the group that I chair throughout the winter, and so it's to review and approve the final plan, and then agree and be happy enough to sign off the assurance statement that needs to get back to NHS England by the end of this month.
Thank you very much, Neil. We've got quite a sophisticated approach to this now. I remember coming in 2021 before when the board was in shadow form and sitting in on the winter planning discussions. Obviously, then it was immediately post-COVID, and a lot of apprehension, I think, about the continuation of the COVID virus and what might happen, but very, very well-structured discussions took place. And so we're building on a very effective programme. Can I just ask, apart from the chronic obstructive pulmonary disease, enhancement. Are there any other major changes of emphasis in the plan? I mean, you've talked about some of the detailed ones, but are there any big, really big changes, or was it felt that the plan's probably fit for purpose without any major change?
I think we're reasonably confident in the plan without any big changes from the last time that it came to board. What we're really trying to do in the second pillar of our priority is around care coordination, and we've made a real push to try and simplify the access to the current alternatives to emergency departments that we have, rather than try to put in a whole load of other initiatives. There's quite a lot of urgent community response services that, if we've just made better use of them, could take the pressure off emergency departments. So there has been quite a bit more concerted effort in that.
Okay, thank you. Any comments or questions? Sam.
Thank you, Chair. No problems at all with the board assurance framework, and as you've said, it's something we've been working on for a number of months now. I was just really intrigued around the point of care testing, Neil, in respiratory pathways and the partnership approach with the life sciences sector around this. Just kind of any sense of where you potentially could see that developing even further?
Yes, so we will be trialling that in a few of our acute respiratory infection hubs. Point of care testing for flu, for COVID, but also you can look at certain inflammatory markers as well to give you aid in decision making if you're going to prescribe or admit. So I think we've tried that there's various bits of work being tried with point of care testing. A lot of the barriers to it are cost. And also the how actually useful it is in the clinical setting to make aid decision making. So we will evaluate it and we'll report that back. If it works well and helps in the management of acute respiratory illness, then of course we'll look to roll that out.
Just very quickly, may I ask? Earlier on today, we heard that we were trying to maintain hospital admissions or hospital beds up to 80% capacity in order to have room for winter pressures. To what extent is that predicated on hospital at home bed use, that particular figure?
So I think that the figure you're referring to is the occupancy levels for our hospital bed. They're getting down to 80%. Now, normally, the occupancy levels run anywhere around about 92%-ish. It's when they get much higher that flow starts to reduce in our hospitals, which then causes quite a lot of performance challenges, both at the front door in hospitals and therefore into the community. So the idea is to try and get occupancy levels just before that Christmas period down to 80% to aid flow. That number doesn't include, I don't believe, any virtual hospital beds out in the community. So we've had a real push in our enhanced respiratory pathway, and Dr. Kath Monaghan, who's a respiratory physician, has been working with her consultant colleagues to try and get better utilisation of virtual ward respiratory beds. So I think it's more about creating some headroom within our hospital bed base prior to what we know will be a busy period over the Christmas time.
Sure, it's just that I noticed an impressive 170 odd hospital at home beds that were going to be utilised. That's quite a lot.
Yes, yeah. So that's of virtual ward capacity, and I'll go back to the point that I was making about we've got some resource out there in both urgent crisis response and virtual ward beds out in the community. We need to, I think, our real focus has been in our planning is to use much better the resources that we have rather than look for endless new initiatives. So that's what we've been looking for to utilise those beds ahead of this winter.
Okay, thank you. And I notice on the last slide that Jacqueline Myers is going to be our winter director. So possible name change to Jacqueline Frost for the rest of the winter, maybe. So we'll break now for lunch and back at 1:10. Oh, I'm sorry. I'm assuming that you approve this. No objections to it. Thank you very much. Okay, 1:10. Going to move to item 17, which is a very interesting and exciting project that the ICB is involved in on a part of a national programme called Work Well. And Dan Jackson, our Director of Policy Investment and Stakeholder Affairs, has been leading on this work, and he's accompanied with Dr. Martin Weatherhead, who's clinical lead, and Claire Mills, Head of Programmes at NEX. And Dan's going to provide an overview of the ICB's Health and Growth Accelerator Work Well programme and tell us what's happening. Dan.
Hopefully you can hear me okay. Yeah, as it's set out in the paper, we've received a funding package this year as one of 3 Health and Growth Accelerator sites in the country to basically try new approaches to tackling the significant and rising challenge of economic inactivity. We're one of 3 ICBs to have received that designation and the funding package alongside South Yorkshire and West Yorkshire ICBs, and we're collaborating with our partners in those areas on this. Because I think it's important to say at the start of this process, there is no blueprint necessarily on how you solve this problem, how you meet this challenge. So we've been given the license to innovate with our partners on some solutions. So just some context, and these are updated charts from those that are included in your paper, but just to give you a sense of the scale of economic inactivity in our region, which is a growing and significant challenge. And it's, as you can see from this chart, it is slightly ticking upwards. It was flat for a while, but now the position is deteriorating in our region. What this means for some of our local authority areas, and unfortunately the Cumbria statistics aren't shown on this slide, but it gives you a flavour of the scale of the challenge, where in some of our local authority areas, up to 1 in 3 working age adults are economically inactive. In other words, because of their unmet health needs, they are not actively seeking work. They are outside the labour market entirely. So why is that important? Well, we know that the connection between economic inactivity and poor health is extremely strong. The impact on healthy life expectancy, it's a massive limiting factor. And this has been reinforced just recently by a joint statement by the Medical Royal Colleges and others that re-emphasise the point that being in good work, and I must stress good work, is really important to good health. So that's why it's such a significant challenge and why the NHS is increasingly getting involved in this agenda. What do we know about the drivers? The text is quite small there, but from a national analysis of fit note data, by far and away the biggest driver of people seeking fit notes, which over time tend to turn into prolonged periods of absence if left untreated, and then economic inactivity, is mental health, particularly anxiety and depression as one of the major drivers of economic inactivity, followed in that chart by musculoskeletal MSK issues as well. And those insights have really helped to shape the programme that we've developed in the North East and North Cumbria. On the subject of mental health, I think this really caught my attention. Certainly, it was a report published in 2022 by the Joseph Rowntree Foundation. And this chart kind of speaks for itself, really. It just illustrates the scale of the challenge in our region. It formerly went off old CCG areas, so the data is slightly out of date, but it gives you it's quite arresting, isn't it, that image, to show that the scale of the challenge of mental health in our region, which is based on antidepressant prescription rates per 1,000 of our population. And in essence, what the Accelerator programme is trying to do is find a better answer to that approach, really. Why is this important? Well, what we do know is that the longer people stay off work, the less likely they are to return. As the point's been made that much like when people stay in hospital for longer than they perhaps needed to or expected to, a kind of physical deconditioning can start to happen. A similar process has been observed in people who stay off work for prolonged periods of time, and that likelihood of return to work diminishes. So therefore, that's also driven our thinking in terms of an early intervention and prevention approach to try and nip these issues in the bud as soon as we possibly can, by working with our GP partners to identify those individuals from their experience who are probably at greatest risk of economic inactivity unless they get a kind of holistic package of support, which is sometimes called something that will meet their biopsychosocial needs to overcome whatever challenges they're facing in their life that may manifest themselves through poor mental health. So that's driven our approach. So what works? Well, the evidence is still emerging in this field, but we're fortunate in our region that we have had for many years now a really effective program run by DWP partners, running them out of primary care settings actually, called the Patient Advisory Service, the PAS as it's known. And part of the appeal of that to GPs is that there is something to refer to for their patients who may present with these complex biopsychosocial issues that may see them become absent from work, but also that it's delivered out of primary care settings, and that's really important to people and helps to initiate take-up on the programme, sustain engagement and deliver better outcomes in terms of sustaining people in work and return to work. And Martin's got some reflections from his experience of how important that is.
Thanks, Dan. So I've been a GP in a deep end practice for nearly 30 years. A deep end practice is one which looks after nationally the highest proportion of patients facing the greatest socioeconomic exclusion challenges. And so my working life has been really based around trying to overcome some of the challenges faced by people posed by the broader determinants of health. And there's no doubt that work and worklessness has a huge impact on people's health. And I think the evidence base is quite clear that good work is good for health. And anecdotally, I think as GPs, we see that all the time. I think that the Patient Advisory Service addresses the big challenge around what is the GP role in terms of sick note certification. There's a big review at the minute. Is there a role for it? Is it going to be separated? Well, I think integrating it into general practice as a sort of universal offer is definitely a way forward. And I think that the PAS service was really innovative and worked really well so that a patient who's referred by the GP gets a biopsychosocial assessment. They meet a lot of the challenges that GPs don't have time to meet, including work, homelessness or housing issues, but also the really crucial things like the interface with the employer, the interface with the DWP, so that can really address some of the myths around what happens in the DWP if you are not given indefinite sick notes. And I think that that approach allows the PAS workers to actually address the real health barriers and identify what are health barriers and what aren't. I think that the other feedback that we got from there is that the clinicians in that service and in the Workwell service, which Dan will mention later, both identified the same things as the evidence, that what they need is some kind of enhanced access into mental health solutions and MSK solutions. And if we have those, and we have a good relationship with an embedded work coach within the practices or aligned to the practices, then we've got a better chance of meeting patients' needs.
Thanks, Martin. So this is a screenshot actually from a film produced by the DWP where they interviewed some of the patients who'd accessed the service. And this is Julie who'd accessed the service in the practice in Billingham. And that's the sort of feedback that we've seen from those patients. And that's really helped to shape our own approach to how we're going to utilise this additional funding. And broadly speaking, they're the three pillars of our programme. The challenge that we were set by government was that health-driven economic inactivity is due to rise by an additional 2,000 people in our region, unless the system can work in such a way to prevent that from happening. So work with us, innovate, try new approaches, build on existing good practice to try and meet this challenge. And that's basically what Pillar 1 is all about, which is basically trying to replicate the PAS model at scale across the whole of the North East and North Cumbria, utilising that funding. Commissioning, in essence, what we're calling the Workwell service, which is very similar to the PAS model, from third-party providers. They could be GP collaboratives, they could be VCSE organisations and so on. Each of our local delivery teams has been given an allocation of money to mobilise that service locally. That's enhanced, as Martin said, by some additional clinical capacity that we're bringing to bear in this area, ring-fenced for this target cohort of patients. We've invested in a patient identification and referral process with our GPs to encourage those referrals into the service locally. We've also been mandated to commission what are called digital therapeutics and technologies. those online tools, apps and so on that have been proven to help sustain good physical and mental health and can help people to stay in work or return to work. So that's broadly speaking what we're doing under Pillar 1. Pillar 2 is all about how we support the health and care workforce, which is a huge proportion of the working age population in our region, as people will know. We have a significant and ongoing challenge with staff absence, which we know does translate over time into economic inactivity. We estimate around 600 colleagues leave the health service in our region alone every year. So what we're doing is we're sustaining an existing model, which is the Staff Mental Health and Treatment Hub, which offers rapid access to mental health support for NHS and care staff. And we are adding some additional features into that model as well and sustaining it using this and expanding it over the course of 25-26. And then finally, under Pillar 3, we're thinking about how we can work with our partners to better support local employers, to promote and increase the accessibility of good work locally in our system. There are existing tools we can use there, such as the Better Health at Work Awards, for example. But there's also the role of NHS anchor institutions. I was just talking to Ken before about the role that large NHS employers as anchor institutions play in their local communities in terms of the people they employ locally, the investment they make in local foundational economies and so on. So we're wanting to get behind that as much as we can through this programme. And also explore how we can make NHS occupational health services more accessible to local employers, because what we hear from the SME sector, the small, medium-sized enterprise sector in particular, is there's a big gap there. They really struggle to get the advice they need to help to keep their staff in work. How will we know if we're making a difference? Well, we're working with national colleagues on a pretty in-depth evaluation of what we're doing. It's very innovative, as I've mentioned a few times. The key measure is what difference we can make to the overall top-line numbers around economic inactivity. But we're particularly interested in the impact we can make on individuals. And we're utilising what's called the EQ5D framework, which measures the impact. It's self-reported well-being tool, basically, that measures self-reported measurement of well-being across 5 dimensions, which are set out there, because we think that'll be a good proxy for how likely people are to therefore stay in work if they're doing well in terms of their health and well-being. So we're at a crucial phase now. We're right into the mobilisation of these services, which are going live throughout October. And I must commend my colleague Claire for all the amazing work she's done on the detail of mobilising those services, working with local delivery team partners across our patch. There's some of the visuals that will be visible in GP practices and other settings going forward. There's some animations and so on the ICB's website, which I'd recommend to you as well. And just to conclude, really, Martin and I have been discussing kind of the history of how mental health is being treated and the fact that the mental health, actually, unmet mental health needs are often at the heart of this problem. And we got to discussing a very old textbook, actually, that was written 400 years ago, actually, in 1621 by an Oxford professor who himself suffered from depression, and it's called The Anatomy of Melancholy. So the language is quite archaic here, but basically his recommendations, I think still stand up and have a lot of wisdom behind them. And they can be summarised as be not solitary, be not idle. And that's in essence what we're trying to do here. We're trying to make sure people can sustain themselves and remain active and sustain themselves in good work as much as possible. And to tackle the solitariness part, because we know that can be a really negative factor in terms of people's mental health, making sure they're well connected, they remain in touch with our services and those of our partners. And we think we're hopeful that that'll make a big difference in terms of this challenge. So very happy to take any questions on what you've heard and what's in the paper.
Thank you. So over for comments and questions. Sir Pally.
Hi, thank you very much. That's been very interesting and very helpful. I think the question that people are afraid to ask, but which I will ask, is what proportion of those who can be identified as being appropriate for this scheme actually, in your view, I mean, I don't mean in philosophical terms, but in mathematical terms, what proportion do you think want to get back to work? So of the many hundreds of people who might be suitable for this program and might well benefit from it. Do you have a feel for what proportion are motivated to get back into work, have the feeling, yeah, I want to do that?
I might defer to Martin on that question, if that's okay, we're giving your experience.
Yeah, I mean, I think that the first thing I would say is that understanding what motivates people and being able to assess and measure it is presented as a science, but actually we're not good as clinicians at knowing who's motivated and who isn't. And people often will say that they don't want to, but that's because they're fearful of the consequences, often consequences that they don't understand. That it might do this to me benefits, it might do this to my work, to my employer. That's the first thing. Obviously, economic inactivity covers a wide gamut of things, including health-related economic inactivity, you know, sickness, certification, but it's also students and people who've retired. So out of, I think it's about a third of the people who are economically inactive are inactive because of sickness or health-related barriers. And out of that, I think that about 2/3, I can't remember the exact figures now, do not want to work. They really don't want to work again, and they're quite explicit about it, even as far as we know. But out of the remaining ones, the experience of the PAS has been that 1 in 3 people that they are referred actually get back to working. And I think that came out of some other work as well. So there's definitely a proportion who will return if we actually address the problems that they are facing, rather than trying to address problems that we think are the problems that they're facing. So it might not be the depression and the antidepressant. It might be actually sorting out with their employer the fact that their current work is not sustainable with the problems that they've got, and that they need to think about doing it differently. And of course that requires then an employment environment which actually is wanting to keep people in work. And at the minute we have some difficulties, as we know, even as an ICB. We don't. There's a lot of organisations looking to lose staff rather than gain them at the minute.
Sam Allen.
Thank you very much. I mean, just firstly, just thank you for all the work that you've done on this. I know we're one of 3 national pilots, and we've secured the funding for a year, but it's very much, its continuity is very much depending on outcomes and results. So I'd be really keen to just hear a bit about where you're at with that, and maybe what you see as some of the risks kind of associated with that. And then just finally, it builds a bit on what you were saying, Martin, about the business community and that kind of connectivity with the business community. And is there anything more we can do on that? Is there any further support that you need on that? I guess initially the awareness amongst the business community of this approach and that it's available, but also what being a good employer looks like. And I think even in health and social care, where we've got the largest workforce, I think we've got some room for improvement there as well.
Claire Riley.
Thank you, Chair. I just want to commend the work of Claire, Dan and Martin, actually. This is a large programme of work that we've had to really turn around rapidly and work with many partners with a collaborative approach. And obviously the involvement with GPs are absolutely instrumental, and the team have successfully signed up a significant proportion of GPs to be part of this work, Dan, so you might want to mention that. But linked to Sam's point are the success of this is really important, because this is where we get then the sustainability of delivery. And I'm pleased that there is a strong data-led evidence base linked to our approach, but also research wrapped into the delivery mechanism of the programme.
Eileen Kaner.
Hi, thank you for the presentation and for all your work in this sphere. I'm sort of interested in the different approaches you might have with, I suppose, 2 groups that I could see. There are those who are, I suppose, formally in work who risk falling out of work. And then there are those people who are out of work, maybe longer term, trying to get back in against the backdrop that Martin's mentioned. You could, I suppose, theorise as to why they might fall, certainly, what might be the issues for those different groups. But how is the programme able to sort of think about those 2 distinct groups.
So, yeah, go ahead, Dan. We'll...
And you raise a really important point, and the Accelerator programme has been located alongside other national programmes, including Connect to Work, which is being led by our combined authorities in the region, which is a nationally funded programme, which is more focused on those individuals who've been out of work for a long time. So what we're saying is where we think the NHS can add the greatest value is working through our primary care system in particular to identify those individuals at risk and support those who are in work but struggling. And we think that's a complementary role that the NHS can bring to bear alongside the work of our partners in combined and local authorities. So they're the two broad cohorts of people we're looking at. Sam's absolutely right that this has been mentioned in the 10-year plan. It was cited as good practice, but it said that if these accelerators have been proven to be successful, we will expect all integrated care boards to establish specific and measurable outcome targets on their contribution to reducing economic inactivity. So the onus is on us, therefore, to prove that they're working, and we're part of that national evaluation process that I mentioned earlier, and also what's called a plausibility analysis, because we're conscious that we're just getting these services going now. We want to influence future national budget setting conversations, so we're working very closely with national colleagues on gathering as much data as they need. Before I hand over to Claire, we might want to say a bit more about impact data. In terms of sign up, we've been really encouraged by the response from our GP community. We're up to over 50% sign up now. I think it's about 180 practices have signed up to the patient identification and referral processes that are central to this approach. But Claire, I don't know if you want to say anything about the impact that we're gathering so far.
Yes, absolutely. And I suppose that also ties into some of the risks that we've been presented with. I'm sure you've understood from the presentation and the discussion so far, this is a systems-based approach, and actually agreeing and capturing that minimum data set alongside putting inside a number of different contractual mechanisms has presented its risks and challenges, particularly flowing data into the national data set and back down to ourselves locally for a local evaluation. So that's certainly been something that's been a challenge. And our outcome measure, because we are focusing on preventing people from falling out of work, it's actually quite counterfactual, so it's very difficult to demonstrate. But working with our partners across the system, we have managed to identify a set of evaluation questions that we're hoping will demonstrate the impact of the approach.
Thank you. Mike Smith.
Martin, John. Yeah, I just wanted to pick up one of Sam's points to answer that, if that's all right.
Go ahead. I'm just everybody be conscious of time. We've got a lot of comments. We've got about another 7 minutes.
Okay, and that is, how do we overcome the risk in time limited funding to have some kind of sustainability of the way of working that we're trying to establish now? And I think part of that is what is business as usual. So the PAS model is actually a zero funded model in DTV. It's using DWP funded staff to work differently. And I think that what we have to try and do is take that. Sure, we can do it on a wider footprint. It can then be sustainable because it's business as usual. We've just got to change almost the way that health interfaces with the DWP and the way that we interact with them. And I think that is a sustainable option. And I think that the other part of that is that the interface with the third sector, with the VCSE, is absolutely crucial. So we know that there's a huge workforce already mobilised out there looking to do the sort of assessment for our patients that we're now trying to introduce as being a sort of a standard part of it. So where I work, for instance, in the Beacon of Light, they've got 4.5 full-time equivalents, work coaches who are employed by the Beacon of Light. The Salvation Army have got a whole-time equivalent work coach employed by them. And that's in addition to the additional resources that are being put in there now. My practice now has a PAS worker, and there's a DWP young persons patient advisory service being developed in the Beacon. So I think that there's a lot there. It's about knitting it together, and the sustainability might be that we knit it together better, and we accept that the fact that we are so integrated in the link that we have to work differently. That, I think, is sometimes the hardest thing for the NHS to do, to change the way it works. as you saw from the melancholy slide, 400 years ago being not idle, and we're talking about it again now. And I think that that's really a bit of a microcosm of what happens in the NHS. It takes us a long time to change.
Go ahead, Mike.
So, absolutely, I fully support this programme. I think it's been a missing piece in the health and care and welfare sector for a long time. I've signed many sick notes in my career where I've thought, I'm signing this with a heavy heart. The patient I know needs the financial security and the confidence that that's going to bring, but I also recognise I'm taking them out of seeing other people and having that fulfilment of work. And I think this is really valuable. My biggest fear, I think has been echoed by many others, is that we don't collect robust enough evidence to justify this programme. If, Martin, as you say, brings essentially a third of those out of work due to health reasons back into the workforce, it will be, on a cost-benefit basis, it will be very, very positive. But if we don't have that data, I can absolutely see this being first on the chopping block when times get tough, and I don't want to see that.
Kelly Angus.
Thank you, Chair, and thank you to colleagues. I think it's a really fantastic initiative, and the one thing I would like to thank you for is the focus on health and care staff. I think a significant investment, and it does make a huge difference. I think the one thing I'm keen in, just picking up Martin's point, time-limited funding, we've got a short period of time to demonstrate that this works, and I think across the health and care employers we could do more to promote what is a fantastic investment in the hub, and mental health is a significant issue for us. We hear a lot of anecdotal experiences from staff, and often staff aren't keen to put their name, but they are keen to share their experience. So it'd be really good to follow up after this, just how we promote that and how we really engage across our health and care workforce and employers. Thank you.
Just a quick comment from me. I'm going to use an old-fashioned word in a minute, but the 4 original goals of the NHS were prevention, treatment, care and rehabilitation, obviously because it was immediately post-war and there were a lot of war injuries to be dealt with. But if you look at the areas of the NHS over 70 years that have been weak, prevention very weak, treatment strong, care somewhere in between, and rehabilitation virtually non-existent most of the time. So a lot of the core skills have been lost in how to do it well, except in certain areas like stroke care, which even that's very variable. But when you look at the past experience, and I did quite a bit of work when I was Chief Medical Officer on the patient self-management programme, and essentially I thought that if you want to fully rehabilitate people, that there seemed to me to be 4 dimensions to it, and I just wonder whether your programme's capturing all of them. Obviously the one that's emphasised quite heavily is the treatment of the core illness itself. So even if they weren't seeking work, what they need treatment for the core condition. So in a way, that's more the technical side of it. But then on top of that, you've got the generic features of long-term illness, the lack of self-confidence, the sleeplessness, the energy levels low, and so on. So that also needs to be rehabilitated. And then you've got the other factor is the non-primary conditions. So people, in addition to having their declared reason for not working, they'll be obese or overweight. They'll have other problems that need to be, that would benefit from being dealt with as well. And then you've got the stuff that you mentioned on your slide, the factors that connect them into work and get them used to the workplace again. So does the programme deal with all 4 of those dimensions?
I think so. I think that's at the heart of that biopsychosocial assessment that the PAS colleagues have pioneered, to take a holistic view of an individual, not just what they happen to have presented with, to find out underlying health conditions, but also relationship with their employer, housing, debt, benefit, advice, childcare, which you can see how you can pull on different partners' contributions into finding a solution, which is at the heart of the locally led approach, the multidisciplinary team approach to meeting those individuals' needs. But I don't know if anything else to add, Martin, on how that's treated.
No, I mean, I think that's absolutely the approach, and I think that even down to the prevention, you know, that part of the funding is being spent on things like making every contact count. You know, starting with preventable causes like, you know, smoking, like alcohol, like obesity. So I think that I really like that analogy about the original sort of rationale for the NHS, and it keeps it. It's still the same now. It's as important now, isn't it? But I think this has tried to tie everything together in the way that you're talking about.
Thank you. Are there any other comments? We'll leave it there. It was a really interesting programme and also beautifully presented. So thank you, and we look forward to. Has it started? When will we start seeing some data?
Well, it's getting underway throughout October, so we'll get the early feedback within a month or two. Yeah.
Chair, if I may, given the impact is so crucial, I wonder if we could incorporate that in due course into the integrated delivery report so that we as a board can just have sight of that. Thank you.
Okay, thank you.
Thank you.
Right, so moving back to item 15, Karen Hawkins, who's deputising for Levi, will be taking us through this item on primary care access recovery.
Thank you, Chair. So the purpose of the presentation and the report included in your pack is to provide the board with an end of programme report on the primary care access and recovery plan, often referred to as PCARP. And it's to provide board members with an overview of what's been delivered during this programme, which formally ended in March of 2025. So this is the end of year report, and the presentation builds upon previous reports that have been presented to the board. So just as a reminder for the board, the Primary Care Access and Recovery Plan, which was first published in May of 2023, and it was to improve access to primary care services. At this time, primary care, like many other parts of the system, were still recovering from COVID-19 pandemic, and before the wider reforms could be implemented that were expected, the Primary Care Access and Recovery Plan set out the need to take the pressure from general practice and tackle the 8 AM rush, and to make it easier and quicker, importantly, for patients to get the help that they needed from primary care. So the plan's now been in place for 2 years, and it's been moved into now the business as usual for practices, and the wider primary care services continue on their transformation journey across the 4 key strands that were in the Primary Care Access and Recovery Plan, which were empowering patients, modern general practice, building capacity, and cutting bureaucracy. So just in terms of the next few slides, they are being provided just to provide a bit of a high-level overview of some of the key achievements that have happened during the 2-year period that we've seen. So promotion and use of the NHS app has improved, empowering patients to take control of their own information through the 4 core functions of access to records, ordering repeat prescriptions, self-booking and management of appointments, and importantly, communicating with their practice. So the ICB has achieved the national requirements through this period, with 99% of practices having the 4 core components of the NHS app enabled, and with practices having the embedded functionality to allow patients to use the NHS app should they wish. Although for the reporting period, the compliance is stated 99%, for board assurance, the NHS app enabled, we have actually as an ICB achieved 100%. The reported figures are nationally reported figures, and they're derived from the nationally reported data. And the ICB digital team have provided evidence to NHS England and the regional team to correct the data, and that's been escalated within NHS England currently. The inaccuracy of the data has resulted from where practice mergers or practice closures have happened during that 2-year period, and they've not been removed from the data collection. And also it included community and walk-in centres that are not GP practices, and they should have been excluded from the data. So that's to provide assurance to the board in relation to the achievement. Record views, there's some really good news stories in relation to record views. More patients are accessing their records through the NHS app. From our original target that we set of 850,000, we have achieved during the period in the previous 2 years 1.54 million. Also for repeat prescriptions, we've seen the same with the target of originally 198 and achieving 333,000. In addition to the NHS app, patients are being supported to take more control of their own health care through self-referrals, and we saw an increase in the number of self-referrals during this reporting period across pathways during 24-25 with the target of 23,466, but actually achieving 30,508, so yet again an increase. Importantly, as we move towards analogue to digital, and this is something that's continuing through Modern General Practice now into 2025-26. Modern General Practice Access supports patients to access GP services through a range of methods and in a consistent way. Practice models have evolved to deliver Modern General Practice through the period, and it intends to improve access and make it quicker for patients to get the help that they need. So that's included, from an ICB perspective, supporting all practices on analogue lines to move to digital telephony and making full use of the digital telephony capabilities. As I say, that work will continue through in 25-26. And it was also to provide all practices with the digital tools for Modern General Practice, and all practices through our digital team and our support offer have been offered support to improve and to implement the digital tools through funding such as eConsult and through the online consultation system through hands-on support from the ICB Digital Support Hub. Implementation of the Modern General Practice supported by investment in the workforce has also shown a 7% increase in our staffing within general practice, and that's largely been supported by the additional role reimbursement scheme available to primary care networks, alongside the inclusion from October 2024, where we're looking at the claimable roles. We did see a significant increase. And in addition, transformational support has been delivered to practices and PCNs through the General Practice Improvement Programme during that period. And a total of 73 practices across our patch have completed the programme in 23-24, with further practices being enrolled onto the programme in 25-26, again to support their transformational journey as we move into new ways of working. So in terms of the areas that we've already covered, a significant amount of work has now been undertaken regarding pharmacy services, and importantly, when we look at primary care, we look at the wider scope of primary care beyond general practice. And it's important that pharmacy services are included because they can offer to patients as part of a wider primary care offer. And our achievements through the PCART period, we launched Pharmacy First on the 31st of January of 2024, and more patients have accessed Pharmacy First consultation pathways. So again, achieving our expected targets and standards. And more patients have accessed blood pressure checks offered by pharmacies with a target of 4,000, and we actually achieved 12.5 thousand in that reporting period. More patients have accessed pharmacy for oral contraception and consultations, creating convenience for patients and reducing demand on general practice through this service. And again, exceeding the targets that were initially set as part of Modern General Practice. There's significant support to build capacity through additional training and education. And we've also been supporting practices through the period around care navigation and training for Modern General Practice. Estates is really important to ensure that we're able to ensure the capacity that's available within general practice. And working with our estates team, there was 12 new clinical rooms completed, providing 85,200 additional appointments during that period based on the appointments per room. There is an estates improvement plan to prioritise estates provision within general practice as we move forward as well. And through 25-26, there is an additional investment of 5.8 million around estates improvement as we move forward. So the next slides provide an overview of the feedback from general practice in February of 25, and that was following the Modern General Practice survey that was issued to practices to feel how they felt about how they'd implemented better digital telephony, simpler online requests, and faster care navigation. It was also to seek assurance from practices about their ongoing journey and to better understand how they'd utilised the Modern General Practice Transitions funding. So for better digital telephony, you'll see within the slides a number of practices during 23, 24 and 24, 25 confirmed that they'd fully implemented better digital telephony, and they also have confirmed that there's a number of practices that have identified that they do not plan to implement digital telephony before the end of 24, 25. There are a full range of reasons why practices during the period of PCARP have been unable to move to full functionality, and that includes whilst they've been working with the providers, while practices are tied into contracts with providers currently, and digital telephony will be implemented through 25-26. But there are some factors where practices are already in contract arrangements with providers that they were unable to get out of during that period. In all occurrences where that has been identified, local delivery teams working with our digital team and also working with our contracting teams have contacted practices that weren't fully compliant, seeking assurance that the practices have a plan in place to do so. Similarly, for simpler online requests, a number of practices confirmed during that period that they'd implemented the simpler online requests, and they were confirmed that they were able to accept online consultations in relation to both clinical and administrative requests during that period. Again, a number of reasons as to why during that period practices weren't able to implement. There was staggering of implementation on functionality of the e-consultation to ensure training, to ensure that processes were embedded both for patients and for staff. There was technical difficulties during that period following changes to clinical systems, and there was changes to the full model that was being implemented from October of this year, so there was staggering. But yet again, from an ICB perspective, our teams have been working with local practices to make sure that they're fully compliant as we work towards the targets in 25-26. Sorry. So I won't go through these slides because I think everybody's got those slides in the pack, but in relation to a number of the areas, it shows where we've demonstrated that we have developed and we have performed in those areas. So I'll go on to the supporting this, and I think this is really important, because without any of this work, we wouldn't have been able to do it without the communication support, and particularly for patients. And it's important that patient education and how to use a system is paramount in terms of any new applications that we're putting in place. And you'll see, and you'll be aware, because it's been reported to board in the past, that there's a number of campaigns that have been led through our communications team and the leadership of Claire Riley to make sure that we have a focused approach in supporting health and well-being. And we also have a number of campaigns that have been successful in winning a number of accolades and making sure that we're supporting frontline teams and trusted voices. So the communications team are going to continue to support throughout this period the promotion of modern general practice. From a patient experience perspective, it's really important, again, that we reflect on patient experience and patient survey results. And although we've seen an increase and we've maintained in some areas good patient experience, there is further information that we need to gather through patient experience surveys and the work that needs to be undertaken to further improve experience. I don't think we can be complacent that actually, because we've done well in some areas, that we shouldn't try to achieve and strive for better as we move forward. There is a patient experience task and finish group that's now commenced work to explore the data and also to gather through the Explain survey and other data sources and identify interventions to improve patient experience of primary care services. And that's including the NHS app promotion led by Health Watch and coordinating closely with the work of the digital team within our teams. The lessons learned in relation to the areas that we've learned, PCARP has enabled consideration of the new ways of working. So over the two-year period, We have looked to how we work differently and how we can move towards transformation of services and support and empower the population to choose the most appropriate way to access primary care. And that's both self-reported information from practices and from the national data. Obviously, we have seen an increase in patient satisfaction. There has been friends and family increase in positive responses. We've seen digital improvements throughout that period, and Pharmacy First has provided the additional choice for patients. So the presentation today has been to look back to 24-25 and 23-24 for the PCARP period. And whilst the formal PCARP programme has ended, we have seen significant improvements, but we need to ensure a continued focus on improvement as the system continues to undergo a transformation following publication of the 10-year plan. And also, whilst primary care are continuing on their own transformational journey, there have been additional contract requirements introduced for general practice in this year and from the 1st of October, including the requirement for the promotion of you and your general practice in the patient charter, and feedback will be fed back through the board in future reports in relation to those new requirements. And we will continue to support practices as they, as I say, continue to go through their own transformational journey to make sure that as strategic commissioners within the health system, that we're making sure that they are supported for good outcomes for our patients. Questions?
Thank you very much, Karen. Any comments or questions? David Chandler.
I didn't think I was first there, but I'll take privilege. So just on the estate side, that £5.8 million, just to emphasise, that's double what we'd normally have to spend in primary care estates. I think that is really good news. And I had one quick question, which probably more from my clinical colleagues, which is from both a GP and a patient point of view, the value and importance of the NHS app.
As a patient, I quite like it. I can, but yeah, I think it's got variable uptake. I think there's much more that the app can do, and that needs to be developed, and it needs to knit together all the different digital solutions that are out there on offer for patients. So I think it again, it's very practice. You'll hear in the next presentation about different priorities for practices, and I think it very much depends on the practice's desire to roll out some of this digital stuff and really embrace it. Will depend how much it's taken up, but it's a step in the right direction, definitely.
I would agree that the potential for the app is huge. Where it's at now is still in the foothills, but I think it's only going to grow from strength to strength. So I think it's about laying the foundations and building it up, but it's going to get there.
Okay, well, thank you. Oh, sorry, Sam.
Yeah. Sorry, Chair, and I think Claire as well. It's a great presentation. Thank you, Karen. And Karen will know, because we talked about this, which is the app and ensuring that we've got consistency across all of our general practices in enabling all of the core features of the app, which I think is incredibly important, because there can otherwise be a bit of a disconnect between the national messaging and what the NHS can do and is there for you, vis-a-vis what your local GP practice has enabled, and have you got access to that as a patient. And of course, being a patient myself, you swap stories with family and friends, and some can look at their record and results, some can't. So I'm really pleased that we have got the 4 key features consistently enabled across all practices. But it does make me think, what further do we need to do from a commissioning perspective to, I guess, enhance patients' access to all features in the app locally through commission services? And equally, what more do we need to do to support the public and patients to understand what the app can do and how they can utilise it? Because I still know, talking to friends and family, that some are using it and understanding it, and some aren't. Some providers are sending correspondence on the app direct, some aren't. Some are still relying on paper. So I think really good progress, but I feel like we have got so much more to do in this area to ensure we've got a consistent service for everybody.
Okay, and just reviewing our timing, we're now slightly over time. I've got 3 more interventions which will remove time from the other present. To do that, that's fine, but if you don't.
Mine's a very quick intervention. It's just a further feature of the app is it allows patients to elect to be part of research, and we know that where people are involved in research, they engage in research, their outcomes are usually improved.
Christopher.
Yeah, just very quickly, it's just that the Health Watch network that's working with the comms team at the ICB, and we are doing a lot of work across all 14 localities around promoting the NHS app. So we'll be out in the community doing that.
Thanks, Christopher, and thanks again, Karen. So we move on. Neil, to your presentation, General Practice Engagement, item 16. Neil O'Brien.
Thank you. So kind of continuing on the general practice theme, we've embarked over the last few months, Sam and I have done a bit of a roadshow around the patch, and we've gone out and sought meetings, conversations and listening to general practice staff. All general practice staff, so admin, nursing, general practitioners, anyone who works within a practice. And effectively what we wanted to do was go out and listen to the challenges, the opportunities that they face in delivering what we've called the core offer of general practice. Quite often with a lot of the new national initiatives, it's all new things, neighbourhood health, digital, all that kind of thing, which is very, very important. But what we were really interested in is that core function of a GP practice delivering for its local population. What were the opportunities and what were the challenges? And we did this in collaboration with the primary care collaborative across the North East and North Cumbria. And we had 4 face-to-face sessions. We had about 170, 180 people attending those 4. We had held a couple of online sessions as well. And then people were also allowed to comment online. And they were facilitated kind of, we had a presentation, a bit of an update on some national stuff, and then some table work and drew that back together. So very briefly, very briefly, the themes that came out, which I want to spend a little bit of time on. Access, the strive for access versus continuity came out very, very strongly. Some practices feel that the national strive to just offer more and more and more appointments at the expense of continuity was the wrong direction. And a lot of people really were looking at innovative ways to try and bring continuity back into the general practice experience, which I thought was a very valid point. The second one is the public perception of general practice. I think we heard some really heartwarming stories about the people's value of GPs, but also some quite distressing stories as well about some either unrealistic expectations of what your GP practice was there to offer, or sometimes some stories when there's been outright aggression, violence, and abusive behaviour towards general practice, and people experiencing that in varying different settings across the patch. We talked a lot about collaboration and integration, and that these were words that were used very often in strategic discussions for when we talked about neighbourhood health and general practice, and that was important to GP practices or the staff that work in practices to varying degrees. Some were finding it very difficult to work with neighbouring practices. Some found it very easy. Some found the value in it. But I think what we started to get a sense of was this growing realisation that general practice needed to start looking more outward. They sometimes struggled with that, needed some help with doing that, but they were certainly realising that this was a job for them to do strategically across the patch, so that was an interesting theme. Workload shift and feeling undervalued in the system was a very strong theme. We've all heard about the collective action that general practice and then our local commission service review. A lot of that is about a perception of work moving out to general practice without the resource to follow it. and lots of tasks being devolved to GPs, therefore, as either the GPs themselves or the staff that work within the general practice felt undervalued professionally in the health service. Estates came up. It was a huge constraining factor within practices improving the offer that they had, but particularly how we manage as an ICB the estates application process came through, that it was too clunky, it required far too much administration. So we've taken these themes back and to put something useful. And the last thing is digital solutions. Everyone's saying there's loads of digital solutions coming at us. There's not a lot of expertise within GP practices to operationalise these. They could see the benefit of them. They weren't the answer to everything, but they could see the benefits. And there's a real desire to take those up. Wrong button. So my last slide is, so what we heard was, not one size fits all. All GP practices are different. They've all got different challenges. The rural versus the urban, the deprived versus the not so deprived. So each practice has its own unique challenge. So there is not a single improvement plan for general practice. It's not possible. We need to tailor our offer and our approach. It's a very complex system, and with lots of change at the moment was a feeling, and we need to be able to flex locally to support that. Real positive feedback from people in the room that we've taken the time to come out and listen. And we were very specific. We want to listen to you. This is your meeting and your agenda. And the value of that, I think, can't be measured. But there's a real desire for that to continue, and we have committed to doing that. But also thinking about our other primary care providers. So we're looking now, can we do a similar thing for community pharmacy, for dental, for Optom? And we'll look to develop that in the coming months. And then just that real feeling that we as commissioners, we have a lot of strategic discussions, being able to feed in exactly the kind of pressures and opportunities from frontline staff into our strategic thinking is vital. And what we'll do is we will take the learning from this and then incorporate that into our 5-year planning as we move forward with our neighbourhood health model. So it was just really to give you the themes of those. There's more detail in the reports. I'm happy to take any questions.
Thank you, Neil. So comments and questions for Neil? What would you place on, where would you place general practice on the happiness scale? Because we're always hearing that they're very demoralised and unhappy. That's what you found?
I think, yes, there is a lot of unhappiness out there, and there's a lot of pressure, but a lot of very motivated people to do a good job. And I think that they're unhappy because they can see the opportunity of the things that they can do. They also can see the value of their work, and they don't feel as though they have the resources and support to do it. And I think that's where the unhappiness comes from. There's still a real belief in the community general practice they offer. I just think that a lot of people feel as though the cards are stacked against them.
Thank you. Jacqueline Myers.
Thank you. Neil, a question for you, and maybe possibly for Karen. Just coming back to your first theme around continuity of care versus access and volume, what do you think as an ICB we could do to promote better continuity of care? Just thinking about the fact that we're reviewing our local commission services, we've got the neighbourhood health development, other things that we could and should be doing to respond to that.
Right, well, the one thing we can do is learning from the best. We've got a couple of real exemplar sites, one in Whitley Bay, and I think Hynenk as well, recently held a session which was focused around continuity of care and building a community of practice. There are some practical things that a practice can do around almost around the personalised list, and some of the digital offers as well. The digital front door can help promote some continuity. So I think it's just really a recognition of its importance, its critical role in safety, and efficiency, and we should try and, as I say, learn from the best and build them in, I think, into our offers.
It's maybe an opportunity through Boost to pull all of that and expose it a bit more. Thanks.
Eileen Kaner. Sam Allen.
Thank you. Having attended all of the events with Neil, I just wanted to emphasise I was really struck by the incredible amount of kind of knowledge, expertise and talent actually that was in the room. And I think it was that sort of salutary reminder that the size of these businesses on the whole are relatively small. So most of the organisations we deal with, even some of our larger voluntary sector organisations, Lisa, have got significant back office functions, they've got technical expertise to draw upon, they've got significant assets where quite often in a practice it'll be the practice manager and a small number of staff and partners as well. So it was that reminder for me about the role of the primary care collaborative and that opportunity that practices have got to work in partnership. And I think that certainly came through in a lot of the conversations. It was, for some, the first time they'd sat in a room together for some time exploring some of these things. And I think the more we can provide the some of the infrastructure support and the enabling support to enable them to do what they're really good at, the better, really.
Thank you. Mike Smith.
Just touching on Jacqueline's point regarding continuity, I've done some work with the exemplar site Neil refers to in Wheatley Bay, and we've developed an index that can measure continuity in a reliable and scalable way. So I'll have a chat with you outside the room about that, Jacqueline, but I think that is something we can push forward.
Okay, thank you. If there are no more comments, thank you, Neil. That's a great piece of work. Thank you very much. And the idea of continuing with it is a good one as well, if you've got the capacity to do that. On now to the independent review of physician associate and anaesthesia associate roles. And obviously there's been a lot of publicity over this and quite a bit of controversy. And as a result of that, the government commissioned Professor Gillian Leng, who's, I think, currently president of the Royal Medical Royals... RES, Royal Society of Medicine, but was the Chief Executive of the National Institute for Clinical Excellence. So, Kelly, you're going to tell us about that.
I am, thank you, Chair. And we'll take the report as read and just provide the board with a summary of some of the key issues in the interests of time. This report is to provide the board with information on the requirements that have been placed on employers emerging from the review. As Sir Liam indicated there, the report was commissioned in autumn 2024, nearly a year ago, and that was completed by Professor Leng. So therefore the review is known as the Leng Review. The review was taken into physician associates or PA roles and anaesthesia associates, which are known as AA roles. So the principal aim of the review was to determine whether the roles of PAs and AAs were safe and effective, and whether or not they worked effectively as members of a multidisciplinary team. The review goes so far to recognise and really highlights the contribution that PAs and AAs have made within the healthcare system, and it also calls for clearer regulatory frameworks and governance structures for PAs and AAs. Across North East and North Cumbria we have just under 100 PAs at this time and a dozen AAs working in various different settings across North East and North Cumbria. NHS England communicated the outcomes of the Leng Review through a formal publication which was issued to NHS trusts and ICBs that went to medical directors or chief medical officers, chief people officers, and also through primary care networks. And that included making NHS trust and ICB chief execs and regional medical directors and regional primary care medical directors aware of the outcomes and recommendations from the Leng Review. Within the publication, there are some proposed changes and some guides for employers, and some of those things relate to changes to job titles. There is emphasis around experience and duties, but also that the job description needed to be reflective of the role of a PA and AA, but also to recognise that the individuals in those roles needed pastoral and professional support. This report just gives an update of the action that is underway across the system for North East and North Cumbria in terms of how we are responding to the review of the recommendations as set out in the correspondence that was issued by NHS England. So we're asking the board today to note the key findings and recommendations from the independent review, note the number of PAs and AAs that are employed across the North East and North Cumbria system. It's not an insurmountable number, but certainly to be assured that all of our NHS employers understand the action that needs to be taken. They are working to support the safe and effective transition and ongoing development of the PA and AA roles across a range of settings. In order to seek assurance for this process, we have the ICB's contracting mechanisms, which David Gallagher and colleagues oversee, and we will be obviously working with independent sector employers to make sure that they are aware not only of the NHS employer requirements, but the requirements for them as independent sector employers, that they implement the recommendations of the review and they respond as required. I'll end there, Chair. If there's any questions, I'm happy to take them.
Have you got any numbers, Kelly, what proportion of medical services in the North East and North Cumbria are using physician associates? Is it 10, 30, 3, 5?
We think there is a breakdown in the report of all of the employers who are using them together with the subspecialties. So there is a wide range. Most of our NHS FT organisations have either PAs or AAs within their employment, but they are across a range of subspecialties. We know we have around 23, I think, in primary care, and they are, again, that... The sites of which they are employed are variable. Some are in very large organisations, some in a bit smaller, but the majority of them do have extensive supervision support within them, working alongside them. But we do have some of our employers, such as our larger organisations, 16 to 20 on site.
Any other comments, questions? No? Well, thank you for the report. Questions from the public, Claire?
Thank you, Chair. We received no questions from the public by the deadline that we have, which is noon on Monday. We have received a question following that deadline, and it relates to dissatisfaction with a primary care practice, and we will respond directly to them.
Thank you very much. And we agreed at the beginning that you didn't have any other business, so we conclude the meeting. Thank you very much indeed.